I'm going to get started. Um, it's a pleasure to see everybody today. And I'd like to welcome all of you, students, staff, faculty, alums, family, and friends to our Department of Orthodontics graduation day. It's really a special day, and it's wonderful to see all of the attendees, not only locally, but from all over the country. So, you know, the Zoom format does have some advantages, right? Our first class of orthodontic graduates completed the program in 1950. So we're celebrating the 71st graduating class. And some of you know this, but some of you might notice that our class of 2021 is composed entirely of women. Okay, and this is the first time that this has happened in our department's history. First time. So congratulations to this class on this distinction. You really are, you know, breaking new ground here. And, you know, I want to say that having a class composed entirely of women is not a fluke, because the class of 2022 also is composed of all women. So the only thing I can say is, for the guys out there who want to be orthodontists, you guys better step up your game, okay? And looking back over the past year, there is no doubt that it has been challenging. Perhaps the most challenging year that many of us have ever faced. You know, fighting the coronavirus would be challenging enough. There have been 30 million cases and more than 500,000 lives lost in the US. And globally, these numbers are 120 million people infected with coronavirus and 2.7 million deaths. These numbers are really, really staggering. And of course, the pandemic has resulted in periods of mandatory lockdowns, hoarding of supplies, economic crisis for many citizens, as well as complete sectors of our economy, and tremendous social isolation for everyone, from our school-age kids to our senior citizens. But on top of coronavirus, our nation has been rocked by deadly instances of social injustice, leading to worldwide protests and much, much, much social unrest, which we've seen here in Seattle. We also had a very contentious presidential election that resulted in a mob storming our national Capitol building, along with what I could not believe, death threats to some of our elected officials. What a crazy, 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 crazy year, really. And for us orthodontists, to put it in perspective, right? We have had it even extra hard. We have had to endure a year in which the very fruit of our labor, smiles, have been hidden due to universal rules to wear masks. Wow. We have really had a crazy year. So, you know, amidst this crazy, crazy year, we have also learned to be more resourceful, inventive, resilient, thankful, and supportive. We've all become Zoom experts, and the remote learning concept has widened our opportunities to be more collaborative and interactive with orthodontists all over the world. We've figured out ways to minimize aerosol generation in our offices and to minimize the chance that airborne diseases can be transmitted in our offices. We've developed vaccines for COVID in less than 1 year. We've incorporated new lingo like PPP, AGP, N95s, fit testing, OSHA, CDC into our daily jargon. We've learned to appreciate the simple things in life, like having a birthday party, traveling, attending a movie or a concert. And we have learned that we are all in this together. And as such, we need to be kind and caring and compassionate. I would like to thank all of the students, staff, and faculty for your resilience, hard work, and positive attitude over this past year. It's been tough, but it's also been a year with lots of opportunity for growth and learning. For our department, almost everything we do has changed. It's really incredible. Almost everything we do differently. But we have not changed the goals and expectations that our founder, Dr. Alton Moore, set for the department almost 75 years ago, to provide the finest education to our students, to prepare them to become leaders in the orthodontic profession, to support the profession through research and service, and of course, to provide patient-centered, high-quality, evidence-based care to every one of our patients. For each of you students, I hope you have maximized your educational opportunities. Yes, I know COVID threw a big monkey wrench in everyone's plans. And sometimes we felt like we had to finish building the plane while we were flying it. But I sincerely hope that each of you feel well prepared to begin your career. And I also hope that you've had some time to reflect on how best to utilize your talents, both personally and professionally. Some time to reflect on what your goals are for the next month, year, decade, and longer, and how each one of you graduating seniors will make this world a better place. It's been a tough year, but trust me, better times lie ahead, and I do wish each and every one of you the very best. Okay. So with that, I would like to also make a few announcements before we begin our students research program. First, I'm happy to say we fully expect to have an in-person meeting for Thesis Day in 2022. And we hope that Peter Nan will accept our invitation that he accepted a couple years ago to be our Alton Moore's lecturer. I'm also very pleased to announce that our next Thesis Day and Alton Moore lecture will be supported by a new fund, the Judith and David Turpin Endowment. David and Judy have generously donated $250,000 toward this fund, $250,000. And this will cover a great deal of the expenses associated with graduation events. I would like to invite all my fellow alums out there to help donate to this fund so that it can eventually cover all the expenses of Thesis Day. I would also like to thank Sue Herring, who has given over 30 years of service to the department. She retired during this past year during the time of COVID. And so we could not even hold a retirement party for her. But, you know, we would like to thank her. And she now holds the title of Professor Emeritus. She has been a wonderful member of our faculty and made tremendous contributions to teaching, science, and service in our department, as well as throughout the entire School of Dentistry. I think my 10 minutes are up. And so with those comments, I will now turn things over to Dr. Burju Berley, who is our Graduate Research Director. She will introduce each of our students in turn. So Burju, please, you've got the mic.
Okay, thanks, Greg. Good morning, everyone. Thanks for joining us. I'm looking forward to introducing these wonderful ladies. Before we get started, after the presentations, we will be answering your questions. It would be great if you can write your questions in the chat, even during the presentation. And if we have time, we will address those questions. And you may use your reaction button to clap after the presentations. So now I'd like to introduce our first presenter, Emily Knott. And the title of her project is Robin Sequence and Mandibular Distraction Osteogenesis, Variations in Craniofacial Morphology and Tooth Development. Emily.
Good morning. Give me just a second to pull up my presentation. Hello and welcome to Thesis Day. My name is Emily Knott, and today I will be discussing Robin sequence and mandibular distraction osteogenesis and the variations in craniofacial morphology and tooth development that follow this procedure. Robin sequence, or RS, as I'll be referring to it throughout my presentation, is a congenital condition characterized by the triad of mandibular micrognathia, glossoptosis, or backward displacement of the tongue, and potential upper airway obstruction. It can be difficult to diagnose and can often be isolated or associated with other chromosomal anomalies, cleft palate, Stickler syndrome, or Treacher-Collins syndrome. It's estimated to occur in anywhere from 1 in 5,600 to 1 in 30,000 births. On the left, you can see an outline of a normally developing infant profile. In striking contrast, to the right is an example of a Robin sequence infant profile. The mandible is severely underdeveloped and is especially deficient in the anterior-posterior plane. These images illustrate the severe mandibular micrognathia and resulting posterior displacement of the tongue. The tongue positioning can cause airway obstruction, and in its most severe form can lead to morbidities such as failure to thrive, cyanosis, cerebral hypoxia, and even death. Patients with Robin sequence fall on a spectrum of severity, and non-surgical management options exist, including prone positioning, nasopharyngeal intubation, and positive airway pressure. These are always preferred if possible and suitable for the patient. More severely affected individuals may require surgical intervention, including tongue-lip adhesion, tracheostomy, and mandibular distraction osteogenesis. Today, we will be focusing on the surgical treatment of Robin sequence through mandibular distraction osteogenesis, or MDO. MDO was first used in the jaw by Rosenthal in the 1930s, but it wasn't really further explored until the 1980s. A retrospective study by CAM of 139 RS patients found that MDO was the treatment of choice for 5% of patients. When distraction osteogenesis is used for micrognathia management, an osteotomy is performed through the posterior mandible. Fixed distractors are incrementally activated to move the bone segments apart, which allows osteogenesis to occur along the surgical site. The tongue attachment to the geniotubercle also moves anteriorly, effectively removing the underlying cause of the airway obstruction. MDO is effective in eliminating airway obstruction in over 90% of infants and obstructive sleep apnea in 97% of children. But due to the osteotomy location, there can be disruptions to the developing dentition and mandibular morphology. The buds of the developing teeth are in close proximity to the osteotomy site and to the location of bone screws anchoring the distractors. During infancy, permanent molar tooth buds occupy a large proportion of the total mandible volume and approximate the inferior mandibular border. The picture on the left depicts the mandible with the KLS distractor used at Seattle Children's in place. Ignore the red line showing a BSSO and instead focus on the dashed lines, which show the inverted L osteotomy technique used by the surgeons at Seattle Children's. This technique for MDO includes bilateral submandibular incisions and inverted L corticotomies with horizontal and vertical cuts superior and posterior to the lingula. The positioning of the osteotomy may influence the likelihood of malformed or missing teeth. In order to understand the effects of MDO, we must first look at how RS individuals grow without any MDO intervention. In general, patients with RS have shorter mandibular and ramus lengths, more obtuse gonial angles, increased mandibular plane angles, and a more open mandibular flexure with a persistent vertical growth trajectory. In a study by Wang looking at patients with RS aged 8 to 9 years, the mandibular plane angle was 9.4 degrees steeper than normal controls. Tooth agenesis in the general population occurs at a rate of 3 to 8%, with third molars, mandibular second premolars, and maxillary lateral incisors being most affected. Tooth agenesis in the RS affected population occurs at a rate of 42%, excluding third molars, with maxillary and mandibular second premolars being most affected. The study most similar to our design is that of PACE in 2016. 10 patients with RS receiving MDO during infancy were described at age 6.8 years and compared to a control group of 10 RS patients without MDO. Significant differences in the RS with MDO group were shorter mandibular length, smaller mandibular body, more obtuse gonial angle, more vertically directed growth, longer anterior facial height, and shorter posterior facial height. The SNA was similar between the RS affected groups, but both RS groups had significantly smaller SNA and SNB measurements than normally developing patients. In a sample of 17 RS infants treated with MDO, significant increases were found in ramus length, gonial angle, and mandibular oblique length, and mandibular sagittal length about 9 months after MDO. Distraction created mandibular morphology more similar to age-matched normal non-RS infants, and their mandibles were significantly different from non-MDO RS mandibles anterior to the gonial angle. This study did not account for long-term relapse or any changes due to growth. A retrospective cohort study of 25 RS patients treated with MDO found increases in mandibular body length, SNB, and mandibular unit length immediately following MDO, but only 2 patients, or 8% of the sample, regained a growth rate in the vector of DO that matched or exceeded normal age and gender matched controls. In addition to potential changes in craniofacial morphology, a potential complication of MDO is disruption of tooth development. When preparing for MDO, careful surgical planning is essential to minimize damage to developing tooth buds and the mandibular canal. Many studies demonstrate adverse effects to the mandibular posterior teeth. This particular study by Peacock showed adverse effects on the teeth proximal to the site of distraction in 42 out of 52 teeth, or 81%, in a study of 26 RS patients treated with MDO. The purpose of this study is to investigate craniofacial morphology and tooth development in patients with Robin sequence who were treated with mandibular distraction osteogenesis in early life, and to compare findings to normally developing patients at infant and mixed dentition stages and patients with RS not treated with MDO at the mixed dentition stage. In order to gain a better understanding of the effects of MDO, we'll aim to answer several questions like, do Robin sequence infants treated with MDO experience changes in vertical and anterior posterior growth as compared to RS patients who have not undergone MDO and to normally developing patients at the mixed dentition time point? Our second question is, do RS patients treated with MDO in infancy have a higher frequency of missing or abnormally developing mandibular posterior teeth as compared to RS patients not treated with MDO? And if so, which posterior teeth are most often affected at the mixed dentition time point? And our third and final question is, are any preoperative, intraoperative, or immediately postoperative factors associated with changes in craniofacial morphology or tooth development in infants with RS treated with MDO? In order to answer these questions, the study was designed to collect data at 3 time points: pre-distraction, immediately post-distraction, and at a mixed dentition follow-up around 6 years of age. Patients were included in the study from 2005 to the present. 14 RS patients were planned for MDO, and they were age and gender matched where possible to a normal control group of infants with head CT imaging for reasons unrelated to RS. Post-distraction, 12 RS patients had satisfactory imaging and medical records for inclusion. At the mixed dentition follow-up, 13 RS patients who had MDO returned. 1 patient was too young for a follow-up, and there were 19 RS without MDO patients and a normal reference control that was sourced from the Michigan growth sample. The Michigan growth sample size consisted of 99 males and 92 female subjects between 4 and 19 years of age. The sample was made up of European Caucasian origin children, and we selected measurements specific to an 8-year-old male and female, which most closely aligned with the mean age at mixed dentition follow-up in our study. The inclusion criteria included diagnosis of RS, partial or complete records at T1, T2, and T3, and treatment at Seattle Children's. Exclusion criteria included not having treatment at Seattle Children's and no available imaging. We kept the sample limited to 1 location for consistency of records and surgical technique. The patient's medical records were evaluated at each time point, and several pieces of information were collected, including at T1, age, height, weight, BMI, and presence of co-occurring condition. We needed to know if RS-affected infants had any inherently different physical growth pattern outside of mandibular micrognathia as compared to normally developing infants, and we needed to track how many patients had isolated RS versus those with other conditions. Intraoperative data, including surgical complications, estimated blood loss, and surgery time were recorded. I also noted mechanical issues and failures of the distractors, as well as the total amount of distraction. At the mixed dentition follow-up, age, height, weight, and BMI were collected. Now I'll take the opportunity to walk you through the process an infant with RS planned for MDO undergoes and how I collected my data. Severely affected infants with airway obstruction are slated for MDO in order to avoid tracheostomy. Typically, this is soon after birth, and an initial head CT image is taken for evaluation. I extracted a lateral cephalogram for tracing purposes. Here's an example of a T1 image. I only traced measurements specific to the mandible as the infant's mouths were wide open and image quality is relatively poor. Similarly, a post-distraction CT is taken once the prescribed course of distraction is complete. Typically, mandibles are advanced until 2 millimeters of negative overjet of the alveolar housings is achieved. The distractors can accommodate up to 30 millimeters of advancement. Gonial angle, ramus height, mandibular body length, and the ratio of ramus height to mandibular body length were the measurements collected at T1 and T2. At the mixed dentition follow-up, a traditional Ceph and Pano image were taken and many variables were assessed, including AP and vertical growth measures. A panoramic film was also taken, And of note, we routinely saw what we thought was a short posterior mandibular height with permanent tooth roots approaching the mandibular border. So we included a posterior mandibular height measurement in the Ceph analysis to look at this. Posterior teeth, including mandibular second primary molars, permanent second premolars, and permanent first molars, were assessed with the tooth assessment grading scale. A missing tooth showed no signs of calcification in any imaging. A tooth with abnormal development exhibited malformation or ectopic eruption. And we also noted if teeth were missing due to caries, dental disease, or extraction. Maxillary tooth counterparts were also graded to serve as a control, since RS patients typically exhibit more missing teeth than a normal population. The median age for initial imaging at T1 was 1.1 months. Significant differences in cephalometric measurements at T1 between RS patients and normal controls were increased gonial angle and decreased mandibular body length. The mandible in the RS patients was deficient both in height and length, but was still proportional. 12 patients with RS treated with MDO had both imaging and surgical data available at the T2 time point. The majority of patients had a co-occurring condition with cleft lip and/or palate, Stickler syndrome, and obstructive sleep apnea most often present. The median patient age at distraction was 1.5 months, and the distractors were in place for 76 days, with T2 CT imaging performed 86 days after the initial surgery date. No patient had intraoperative complications during MDO surgery. Blood loss was minimal and estimated to be less than 10 millimeters. Postoperative complications were infrequent. 3 patients had mechanical issues with the distractor. 1 distractor failed and was replaced in a second operation. And 1 patient had a second operation because the osteotomy on one side did not open. Other complications included backward auto-rotation of the distractor arms and a stuck ratchet. 2 patients had postoperative MRSA infections, which resolved without early removal of hardware. The mean mandibular advancement during MDO was 22 millimeters, and overall the distraction process was completely carried out in each infant. The small sample size and low rate of complication prevented statistical analysis of how intra and postoperative factors may have affected the surgical outcome. Differences between the T1 and T2 imaging can be attributed both to growth and side effects of MDO. Significant increases were recorded in ramus height and mandibular body length. Gonial angle changes were variable and not significant, and although statistically significant, the small change in ratio of ramus height to mandibular body length was not clinically significant. Between the T2 imaging and mixed dentition follow-up T3 imaging, both linear and angular measures changed significantly for the RS with MDO group. Vertical growth tendencies persisted, as seen by significant increases in both gonial angle and the ratio of ramus height to mandibular body length, showing backward rotation of the mandible. So imagine that you're in practice and these patients present to your office. Do these mandibles look normal to you? At T3, patients often had irregular contours of the border of the mandible, significant antigonial notching, very obtuse gonial angles, and extremely steep mandibular plane angles. I've broken down the T3 cephalometric values into several categories, starting with anterior-posterior. Although A and B was increased in the MDO group as compared to the non-MDO group, the difference was not statistically significant. The RS affected groups were significantly different from the reference control for SNA and SNB, but not A and B, although the confidence interval was large and had a high range. The linear mandibular Ceph values were similar for RS with MDO and RS without MDO groups, but they were very different from the reference control group, with both ramus height and especially mandibular body length measuring quite small. The ratio of ramus height to mandibular body length for RS with MDO patients and the reference control was the same. The angular vertical Ceph values really showed where the MDO group differed. The gonial angle was significantly more obtuse, and the mandibular plane was significantly steeper. Y to SN fell just outside the range of statistical significance, but it was increased in both RS affected groups. All of the angular vertical Ceph measures were very different from the normal reference controls. The only linear vertical Ceph value that was statistically significant for the MDO group was increased anterior mandibular height, but it was also the only variable that was not statistically significant in comparing RS affected patients to the normal reference control. In evaluating the tooth assessment grading data, comparing missing, abnormally developing, and extracted primary second molars, permanent second premolars, and permanent first molars, the only significant finding was that RS with MDO patients experienced more frequent abnormalities in mandibular posterior tooth morphology than RS patients without MDO. 30% of RS with MDO patients had one or more mandibular posterior teeth affected. The most commonly affected teeth were the permanent second premolar and first molar and the primary second molar. In the panoramic film on the right, this RS patient who had MDO is missing both mandibular second premolars, but the RS with MDO patients did not have a higher incidence of missing teeth in our sample as compared to RS patients who did not have MDO. With these results in mind, we have to remember what the true purpose of mandibular distraction osteogenesis is for the severely affected RS infant. Mandibular distraction osteogenesis is a viable treatment alternative to long-term tracheostomy in RS patients with severe upper airway obstruction. Ideally, the horizontal deficiency of the mandible would be corrected by MDO and would be maintained throughout growth, resulting in more normalized craniofacial morphology. Of utmost significance to the child, their family, and healthcare providers is that tracheostomy is avoided. In this sample of infants with RS, MDO was successful in alleviating severe upper airway obstruction, and no patient required tracheostomy. There was no mortality associated with the procedure, and the morbidity was minimal. All patients completed their planned course of mandibular distraction. We saw that RS patients that had MDO did not make positive improvements immediately following MDO, but vertical growth trajectory returned by T3 presentation. The gonial angle significantly increased 12.6 degrees on average. The ramus length and mandibular body length increased as we would expect from normal growth, but the increased ratio between them indicated backward or unfavorable rotation of the mandible. The positive cephalometric outcomes found immediately following MDO were not maintained at the mixed dentition time point. Our results showed that RS with MDO and RS without MDO patients resemble each other in the mixed dentition, but vertical angular measures are significantly increased in the MDO group. Let's take a look at gonial angle at T3 for each group. The first mandible depicts the normal control average gonial angle at 129.1 degrees. The RS without MDO mandible has a more obtuse gonial angle of 143 degrees, and with the addition of MDO, the gonial angle becomes even more obtuse at 152.5 degrees. We can see that MDO did not normalize mandibular morphology at all for this parameter. When we superimpose these mandibles, we can see that MDO did not restore normal mandibular morphology long-term. The mandible has rotated unfavorably backward, and the RS-affected mandibles more closely resemble each other than that of the normal control. We have to keep in mind that the RS group that did not have MDO was less severely affected to begin with. But if the secondary goal of MDO is to normalize mandibular morphology to that of the reference control, or even to the sample of RS without MDO patients, this sample did not show that that could be predictably achieved. In addition, this follow-up assessed patients around the age of 8. What would this sample look like when the growth velocity rapidly picks up in puberty and the mandible continues on its current path? Would the difference be even more pronounced? Following a sample into adulthood would be extremely helpful to evaluate long-term implications. Switching gears to look at tooth development, we had a very interesting finding We expect the corticotomy location and surgical technique influence the likelihood of damage to developing tooth buds in the posterior mandible. With the inverted L corticotomy technique, we found that 12 of 78 teeth proximal to the corticotomy were adversely affected, in stark contrast to the study by Peacock that found 81% of teeth next to the corticotomy site having adverse effects. There were some limitations to our study that we should recognize. The sample size was small due to the rarity of RS patients, and especially those so severely affected that MDO is indicated. We also restricted the sample to STH, or Seattle Children's, for ease of access to records and uniformity of surgical technique. The sample is heterogeneous, as not all infants had isolated RS. In addition, the RS without MDO group is not a direct control group, as they were less severely affected to begin with. Our sample was collected over a period of 15 plus years, so imaging quality and consistency varied, making some landmark identification difficult. 5 sets of patient records were retraced and regraded, and the Pano grading was 100% consistent, and the Ceph tracing showed excellent intra-examiner reliability with excellent intra-class correlation coefficients for all measures except 2, where the absolute error was very small. Lastly, the sample couldn't be randomized for ethical and practical reasons. So how do we treat this patient in the future? If they were to present in your orthodontic office, would traditional comprehensive orthodontic treatment be indicated? Or could the possibility of functional deficits or unfavorable aesthetics exist that might require surgical orthodontic treatment, extraction of permanent teeth, or possibly placement of dental implants? Should you treat these patients in phase 1 when they have a high likelihood of continued vertical growth and they've demonstrated little horizontal growth? This topic is pertinent in that by improving a horizontal deficiency of the mandible early in life, altered growth patterns and developmental dental anomalies can persist, which may limit or complicate further treatment. Continued research on this topic could evaluate different surgical techniques and include more patients with a longer-term follow-up interval. It would be interesting to follow a sample of patients into adolescence and adulthood to track if additional surgical procedures are needed to meet functional and aesthetic desires of patients with RS. In conclusion, I would like to thank my committee members, Dr. Scheller, Dr. Greenlee, Dr. Susarla, and Dr. Evans for the mentorship, wisdom, and expertise they contributed to my research. I learned so much and feel I've developed into a more critical thinker and better problem solver with your encouragement. And to Dr. Scheller, especially, I want to thank you for your incredible time investment and thoughtful leadership, both in my research process and to me personally. I respect your work ethic, caring nature, positive attitude, and commitment to advancing the orthodontic and greater dental community as a whole so much. I hope to emulate the model you showed to me as I transition to the next stage of my orthodontic career. Thank you to the University of Washington Orthodontic Alumni Association for making today possible and for providing funding for my research. We are so grateful for your support. Thank you to my amazing husband, Ryan, my parents and siblings for always encouraging me. We've been looking forward to today for so long. I originally applied to UW for orthodontic residency after the orthodontic faculty at my dental school, University of Kentucky, recommended this program. After doing my own research, I came to realize how well respected the program is and its graduates are in the orthodontic community. I told my husband I would be shocked to receive an interview, much less matched to UW, and to my great surprise, I found myself moving to Seattle just a few short months later. I came to Seattle having visited for my interview and having no community, but now find myself leaving with a new family. To our amazing full-time and part-time academic and clinical instructors, thank you for sharing your wisdom and giving your time to support us in our education. I appreciate your efforts tremendously and hope you know how valued you are. To our amazing staff, Becky, Stephen, Colleen, Taryn, and Ellen, thank you for supporting us, answering endless questions, and always having the candy drawer stocked. To our wonderful assistants, Leanne, Nahid, and Jacqueline, thank you for working so hard to make our clinical experience so positive. We learned so much from you, and I'll miss working with you all each day. Lastly, to my co-residents, thank you for your incredible friendship over the past 3 years. I love my class and feel honored to be a member of the first all-female graduating class. I'm excited to celebrate your future successes and know it won't be long before we're hosting many seminars with each other as we venture out into the real world. I'm so grateful for my time at UW and will sincerely miss you all. I hope to represent UW well as I start my orthodontic career in Charlotte, North Carolina. Thank you so much for your attention, and I'm happy to answer any questions you may have at this time.
Thank you, Emily, for a great presentation. So I see, I don't know if you're able to see the chat, but I see two questions in the chat. I think we could definitely answer the first one. We're running a little late. So I'll read the question. This first question is from Mike Harefield, and he says, thank you for your contribution. Considering that only 8% of children achieve somewhat normalized growth patterns following treatment, do the surgeons try to overcorrect the advancement, anticipating a limited response? How long can the osteotomy be kept open with the distractor in place?
I'm not sure I can totally address all of those questions, not having a surgical background, but the main objective of the surgery is to avoid tracheostomy. Obviously, we'd like to achieve a growth vector that's normalized, but not always possible. In this case, the distractors and the osteotomy site was left open for 2 to 3 months, and that seemed pretty standardized. They do overcorrect until negative overjet is achieved. Oftentimes, teeth haven't erupted yet with the age of the patients, but at least until the alveolus, upper and lower, are in a negative overjet relationship. So they do try to build that in, but unfortunately, the growth trajectory of these patients is just so strong that it overcomes the surgical correction. And why I mentioned another really interesting aspect to this study moving forward would be to assess these patients at later time points to see a secondary surgical correction and what that entails.
Okay, thank you. I think we can probably answer the second question too. Irina Baker is asking if are there any other designs of the osteodistraction apparatus available?
For the distractors, to my knowledge, yes, but this is what they use at Seattle Children's. I believe they can be internal and external, but we just limited our sample to Seattle Children's for consistency purposes, and they use the KLS distractor I showed.
Okay, thank you very much. So I think there are some more comments in the chat, but I think we're not going to be able to answer any more questions. So now I would like to invite Dr. Barbara Scheller to discuss Emily's project.
Thank you, Berku. To the graduating orthodontic class of 2021, I offer my remote, safe, and very sincere congratulations. Welcome to the family of proud University of Washington orthodontic alumni. Thank you, Dr. Emily Knott, for choosing a craniofacial thesis project, executing the research plan meticulously, and presenting it elegantly. Your findings contribute to the evidence base supporting craniofacial surgery techniques and orthodontic treatment of these patients. Analogous to how TADs, aligners, and intraoral scanners changed orthodontic practice, in the past 15 years, distraction osteogenesis shifted the paradigm of craniofacial surgery at Seattle Children's Hospital and around the world. When surgery is done for an infant, it is important to understand the long-term effects, including craniofacial growth and tooth development. Craniofacial centers using MDO for infants with airway compromise are just now at the point where a critical mass of patients have reached the mixed dentition stage for analysis such as Emily has performed. Dr. Knott's key finding is that the mandible size, shape, and growth vector are not normalized by infant MDO, when these patients are evaluated at the mixed dentition standpoint. The future orthodontic and surgical treatments needed to create a functional aesthetic occlusion for these patients can and should be a thesis project for a future orthodontic resident. Emily, you've been a mentor's dream throughout this process. Intelligent, interested, independent, communicative but not needy, collaborative, thorough, and charming. These same attributes will serve you well throughout your soon-to-be successful orthodontic career and life beyond orthodontics. I will really miss you, and my very best to you.
Thank you, Barbara. And now I would like to invite Dr. Emery Boland for the presentation of Emily's certificate, a virtual presentation.
Well, Emily, here's your certificate, which is upstairs. And please, after thesis day, come on up and pick it up. And I'd love to give you a big hug and congratulate you on a fantastic program. We enjoyed having you with us. Congratulations. And I hope everybody can join me clapping and wishing Emily well. Thank you, Emily. All right, Borju.
Okay, thanks, Anne-Marie. Now we're, of course, running a little bit late, so we will go ahead with our next presenter, who is Gabby Aragon-Meyer, and her project is Orthodontic Treatment-Induced Changes in Occlusal Contacts in Subjects with Class 1 and Class 2 Malocclusions. Gabby.
Good morning, everyone. To start off, I'd like you all to meet Gavin. So he came into the UW Ortho Clinic a few years ago, and he was very eager to start treatment. He had a pretty significant anterior open bite, and his chief complaint was that he would like to be able to eat and chew better. Now, we know that we can improve Gavin's open bite, but what do we know about the effect of malocclusion on a patient's chewing ability? And what do we know about how orthodontic treatment can change occlusal contacts? The title of my research is Orthodontic Treatment-Induced Changes in Occlusal Contacts in Subjects with Class 1 and Class 2 Malocclusions. Now, looking back at a little history, in 1949, Yerkstus was the first to publish a paper where he and his collaborators found a very strong relationship between masticatory performance and occlusal contact areas. Later, in 1993, Wilding found that occlusal contact areas in an individual are good predictors for chewing efficiency. In 2002, Owens and collaborators found that subjects with greater areas of occlusal contact and near contact were more successful at breaking down food than those with a reduced occlusal contact area. Later, in 2011, Lepley found, while looking into different contributors of masticatory performance, such as maximum bite force, body size, and chewing cycle kinematics, and occlusion, they found that the most important determinant of masticatory performance was in fact occlusal contacts. A later study by Laird's team found that increased functional occlusal areas are related to a greater chewing efficiency for foods of all consistencies. So how does malocclusion play into occlusal contacts? Previous research using test foods has found that subjects with a malocclusion have decreased masticatory efficiency, and they have significantly smaller occlusal contact areas when compared to those that have a normal occlusion. When looking at AP malocclusions, English found that subjects with a Class 3 malocclusion had the lowest masticatory performance, followed by those with a Class 2 and Class 1 malocclusion. Wilding found that subjects with reduced occlusal contact area compensate for their malocclusion by chewing for longer periods of time before swallowing, but that is still not quite enough to completely compensate for their decreased chewing efficiency. Although many studies have demonstrated that malocclusion is associated with a reduced functional occlusal area and an altered masticatory efficiency, there aren't that many studies that have investigated the effect of orthodontic treatment on occlusal contact areas. One of the first studies that did explore how orthodontic treatment contacts compared to those with a control group of patients that had not received orthodontic treatment. And what they found is that patients that had received orthodontic treatment did have a permanent reduction of occlusal contacts, which may not recover even after long periods of occlusal settling. While this study did match subjects for age and sex, they did not explore the effect of angle malocclusion, and they did not compare the pre and post-treatment occlusal contacts of the group that did receive orthodontic treatment. A more recent study looked at occlusal contact areas in patients who received non-extraction, 2 premolar extraction, and 4 premolar extraction orthodontic treatment. And what they found is that immediately after orthodontic treatment, occlusal contact areas reduced by approximately half of the pretreatment value. They also found that occlusal contacts in the non-extraction and 2 premolar extraction groups settled and recovered in about 2 years, but the contacts in a 4 premolar extraction group did not really recover. On the other hand, though, a different study reported that patients who started and finished treatment with class 1 molar relations and had extractions of 4 premolars had significantly greater contact areas than patients who began and finished orthodontic treatment with a class 2 relation and only received extractions of maxillary premolars. These studies have used pretty different techniques of occlusal registration. Yerkstus and many others had patients bite down on wax wafers and then recorded the amount of light that came through these perforations. Later studies used silicone-based registrations taken at MIP, which were then scanned and analyzed on computer software. Yoon, for example, used pressure-sensitive films and had participants bite down on the film with maximum force for 5 seconds. Now, each of these methods have different limitations. Intraoral digital scanners have become widely used in orthodontic practices. Scanners have been demonstrated to be more comfortable and more efficient while still maintaining impression accuracy. Software like GOM Inspect can be used to evaluate data from 3D scanners, and a recent study found that analysis of occlusal contacts by this type of software is significantly more accurate than analyzing contacts based on the traditional physical interocclusal records. In order to objectively compare orthodontic treatment results and to quantify the improvement achieved from treatment, indexes have been developed. The PAR Assessment Index is a widely used, valid, and reliable method to objectively evaluate the orthodontic treatment outcome. It looks at both the pre-treatment and post-treatment models using the same criteria to evaluate both time points. Essentially, the greater the score, the more the case deviates from ideal alignment and occlusion. And the difference between the pre-treatment and the post-treatment scores quantifies the improvement achieved through treatment. Studies have shown that a reduction of about 65% of the PAR score is considered a great improvement in overall alignment and occlusion. So going back to my study. The purpose of my study was to measure the occlusal contact area at pre-treatment and post-orthodontic treatment and determine the pre to post-treatment change, as well as to evaluate the effect of several factors, such as the type of AP malocclusion, initial overbite, age, gender, and extractions on these changes, as well as to determine the correlation between occlusal contacts and the PAR score. This was a retrospective study on consecutively treated patients where we compared the changes in occlusal contact using 3D images of patients that we got at T1, which were their pretreatment scans, and T2, which was immediately after debond. IRB approval was obtained through the University of Human Subjects divisions before starting data collection. We looked through patients that started treatment at the UW Ortho Clinic between January of 2017 and June of 2019. The inclusion criteria were having received comprehensive orthodontic treatment, having good quality initial and final iTero scans with an erupted permanent dentition of first molar to first molar in both arches. Exclusion criteria were having a class 3 or subdivision malocclusion, impacted permanent teeth, retained primary teeth, use of orthognathic surgery, having received dental prosthetic treatment during T1 and T2, treatment with clear aligners, and having unfinished or prematurely discontinued treatment due to reasons such as missed appointments or poor compliance. Data related to patient demographics such as age and gender and extractions for orthodontic treatment was collected from their digital charts, while data regarding the initial type of AP malocclusion and the overbite was collected from the participants' digital scans. Initial and final PAR scores were obtained through the clinic's archives. And at each time point, as I mentioned, patients underwent an intraoral scan with the same generation of iTero scanner at the UW Ortho Clinic. The T1, as I'd said before, was the initial pre-treatment scan, and the T2 was a final scan at the day of debond. The intraoral scans were then exported from mycadent.com as a single open shell STL file and were then imported into the GOM Inspect software for their analysis. So here's just a brief video showing this process. The STL of the mandibular teeth was imported into the GOM Inspect software as a mesh, and the STL of the upper teeth was added as a CAD body. The upper model was then selected and inverted. As you can see there, the model is being selected and we inverted it. And then we're able to outline the occlusal table. Here I'm looking at the overall segment, which is a posterior plus the anterior segment. And at this point, then we could start looking at what was a heat map. Here we could start setting the upper and the lower limits of the ranges that we would later look into, and I'll go into that in a second. The amount of contact from each range was displayed on this statistic table, and the data was then entered into an Excel spreadsheet. This process was done for the overall contacts, as you can see here, from 7 to 7, and it was later repeated for the anterior contacts, which you can see here from canine to canine, and was later done for the posterior segment as well, which was premolars and molars. If in the scan, the second molars had not erupted for the T1 scan, they were not included in that range, and they were later not included in the T2 scan either. So this is a review of the contact ranges that I looked at. So the first range was that of tight contact, which was from 0.25 to 0 millimeters. And I want to point out that this 0.25 represents what's called a collision between the upper and lower digital models. So in physical models, this would represent a distance of 0 where there is no space between opposing teeth, but digital models aren't really able to stop each other from kind of slightly going through each other. In the near contact range, that was from 0 to negative 0.25 millimeters. Anything negative represents a space or a gap between those opposing teeth or that certain area of those teeth from the upper model. Approximating contact was from, again, a space of 0.26 to 0.5 millimeters. Open contact was anything from 0.51 to up to 1 millimeter of space, and no contact was anything greater than a millimeter and up to 1.25 millimeters of space. With regards to the verification of measurement error, 4 months after initial measurements, 5 subjects were randomly selected and their T1 and T2 scans were remeasured. The measurements obtained at these 2 sessions were compared to verify intra-examiner reliability and measurement error. The reliability was excellent with an ICC of 0.99 for all measurements. These tests were also performed on the pre-treatment and post-treatment contact measures separately and also demonstrated excellent intra-examiner reliability. Based on some pilot data of an initial sample of 17 patients, we did run a power sample size calculation. And we found out that to have power of 80%, we would need a sample of 128 patients. And that would also give us around 99% power to demonstrate change in contact area equal to 0.5 standard deviations based on a 2-sided pair t-test. So going over our data analysis, for each type of contact, the mean and standard deviation were used to summarize the amount and percentage of the total contact at pre-treatment, post-treatment, and the change between pre and post-orthodontic treatment. A 95% confidence interval for the average change was also computed. And to test for a change between the pre and post-treatment, multivariance analysis of variance was used. First to test for any change among the 5 contact types, and then we had paired t-tests to test for any change in each of the contact types. And to account for this multiple testing, the paired t-test p-values were adjusted using the Bonferroni method. The amount and percentage of contacts were compared by various patient characteristics such as gender, age, and angle malocclusion, class 1 or class 2, initial overbite, use of extractions as well. So going over our patient selection, we started out with 396 patients that started treatment between the time points I mentioned before. We had to exclude 15 due to poor quality initial scans. Later, after applying the exclusion criteria, we were left with 156 patients. Of those, we had to exclude 39 because the class 1 non-extraction group was already full, and that left us with 117 patients. Of those 117, 21 who had already initially been included had to be eliminated because they had not finished treatment on time. This was secondary to the COVID clinic closures, and that left us with a final sample size of 96 patients that were included in this study. Now, looking a little bit at the demographics, the female and male participants were pretty equally balanced. When looking at the age, you can see the great majority of patients were adolescents, and we only had 9 subjects in the adult group. We had subjects with class 1 and class 2 malocclusions, and we also had subjects with normal, deep bite, or open bite. When looking at extractions, we had patients that received non-extraction orthodontic treatment. They had extractions of maxillary premolars only, and they had extractions of 4 premolars. So, what did we find? I'm going to start off with our pretreatment findings between the various groups. So looking at pretreatment differences in occlusal contact due to age, here we have the combined of the tight, near, and approximating contacts together, and the open and no contacts. And while there was no statistically significant difference due to age, we did find a trend in the overall and posterior segments where the adolescent patients had on average a smaller amount of contacts in all ranges than adult patients. But again, this difference was not statistically significant. With regards to pretreatment differences in gender, there was no statistically significant pretreatment difference in the overall or posterior segments for any contact range due to gender. In the anterior segment, however, there was a significant difference for the approximating contacts. Males had a greater mean amount of approximating contacts than females. Looking at the angle malocclusion, class 1 patients had a significantly greater amount of tight, near, and approximating contacts, as well as of open and no contacts than class 2 patients in the overall and the posterior segments. In the anterior segment, there was no statistically significant difference between these groups. There was no statistically significant difference in overall or posterior contacts due to overbite pre-treatment. However, there was a significant difference in the anterior segment. Patients that started off with a deep bite had the greatest amount of anterior contact, both in the tight, near, and approximating range, as well as the open and no contact range, while patients with the open bite had the least amount of contact in both of these ranges. When looking at pretreatment differences between the non-extraction, 4 premolar extraction, and upper premolar extraction groups, patients who would later receive extractions of maxillary premolars only had the least amount of tight, near, and approximating contact in the overall and the posterior segments. But there was no statistically significant difference in contact in the anterior segment between these groups. So, after reviewing some initial differences between the groups, how did orthodontic treatment change the contacts? Overall, the tight, near, and approximating contacts decreased after orthodontic treatment, while the open and no contacts increased. Here's a table looking at the percent change. Areas of tight contact pre-treatment were about 2.4% of the total occlusal contact area within range. And at post-treatment, they had reduced to 1.2%. This is about a 45.8 reduction from their pre-treatment values. The areas of near contact at T1 had a mean of 14.2% and had reduced to 9.7. Approximating contacts also reduced with orthodontic treatment, while open and no contacts increased. Looking at the anterior segment, which was from canine to canine, there was a significant decrease in the tight, near, and open contact, and there was an increase in the open contacts. The approximating and no contacts were not significantly different. In the posterior segment, there was a significant decrease for the tight, near, and approximating contacts, and there was a significant increase for the open and no contacts. Now, looking at differences between the groups. While there was no significant differences in change of occlusal contact due to age, there was some evidence that adult patients tend to have a greater decrease of tight and near contacts than adolescent patients. But as I stated before, we only had 9 patients in our adult sample, so this group was too underpowered to find any statistical significance. When looking at gender, there was no significant difference between pre- and post-treatment change in occlusal contact between females and males in the overall anterior or posterior segments. But when looking at the post-treatment differences in gender, in the overall and posterior segments, there were no statistically significant differences, But again, in the anterior segment, males still had a greater post-treatment amount of near and approximating contacts than females. With regards to differences in the pre and post-treatment change in subjects with a class 1 and class 2 malocclusion, there was a significant difference in the change of amount of contacts in the near contact range, where subjects with a class 1 occlusion had lost on average almost double the amount of contacts than those with a class 2 occlusion. So since class 1 subjects lost a greater amount of contact than the ones that had a class 2 occlusion, it's not really that surprising that after treatment, there is not a significant difference between tight, near, and approximating contacts in patients of those two groups. However, subjects with a class 1 occlusion did still have a greater amount of open and no contacts post-treatment than those with a class 2 occlusion. Therefore, subjects with a class 1 malocclusion finished with a greater mean unit of contact than patients with a class 2 malocclusion. The initial amount of overbite had no effect on the change of overall or posterior contacts. However, in the anterior segment, subjects with a deep bite lost the greatest amount of tight, near, and approximating contacts during treatment of all groups, followed by those that had a normal overbite, where patients that had an open bite actually gained tight, near, and approximating contacts, as well as open and no contacts. So because there was this big difference in how the contacts in the anterior segment changed for these patients with different overbites at T1, they also did not have a significant difference post-treatment. Looking at the effect of extractions at the T1 and T2 change in occlusal contacts, open and no contacts increased for subjects that had non-extraction treatment, while they decreased for those that had extraction treatment. Despite this, the subjects with non-extraction and 4 premolar extraction still had the greatest amount of post-treatment contact. The upper 4s group only maintained the least amount of tight, near, and approximating contact. When analyzing areas of tight, near, and approximating contact together, we also found that there are differences between class 1 and class 2 extraction patterns. Class 1 malocclusions who underwent extractions of 4 premolars had a mean decrease of about 72 units of contact, where patients who had initial class 2 malocclusion and underwent extractions of 4 premolars had a decrease of only 13 units. Patients who had a class 2 occlusion and had extractions of maxillary premolars only had a decrease of 52 units. So although both the class 1 and class 2 4 premolar groups both had extractions of 4 bicuspids, there was a significant difference in their change, where class 1 extraction group had the greatest loss of tight, near, and approximating contacts, followed by the upper 4s group, and the class 2 4 premolar extraction group had the least reduction of these contacts. So for a quick overview of the PAR scores, the vast majority, that's around 94% of the subjects in this study, had a 60% or greater improvement of their PAR score, with 47 subjects having an improvement between 90 and 100%. 1 had no change and 3 worsened. A greater improvement of the PAR score was correlated to a greater decrease in the percentage of near contacts for the overall occlusal area, and a greater improvement in the PAR score was also correlated to an increase in open contacts. So while we did find a correlation between changes in contact and the PAR score, this was not necessarily in the direction we had expected. So the PAR score may not be the best tool in predicting change in occlusal contact. So let's recap. Orthodontic treatment causes a mean decrease in areas of tight, near, and approximating contact, while it increases areas of open and no contact. Pre-treatment, subjects with a class 2 occlusion have lesser amount of contact than those with a class 1 malocclusion. Deep bite subjects have the most anterior contact, while open bite subjects have the least. And patients that will receive upper 4s extractions have the least amount of tight contact. Looking at the T1 to T2 change in the post-treatment differences, class 2 malocclusions where 4 premolars are extracted have the least decrease in tight, near, and approximating contacts. There is no T2 difference between those who started out with an initial normal overbite, deep bite, or an open bite. And those who have extractions of maxillary premolars only will still have the least amount of tight, near, and approximating contact, as well as open and no contact post-treatment. So like all studies, this one does also have strengths and limitations. The strengths of our study is that we included consecutively treated patients with a relatively large sample size. This study also explores the effect of extractions in different malocclusions. Previous studies did not really look into differences between class 1 and class 2 extractions, for example. We also used 3D images obtained from iTero scans, which have become widely used in orthodontic practice. Limitations of this study are that we didn't explore the effect of settling on the occlusal contacts, although previous research has shown that with settling, contacts will increase over time. The PAR scores were obtained also from the clinic archives, and we don't really have any data regarding the reliability of the scoring process. We were also not able to identify or exclude any subjects with TMD. And another limitation of this study is that the GOM unit is kind of an arbitrary number, which the software computes from a mathematical model. And we do not yet know how this relates to clinical measurements. Future studies that would look into the association between this GOM unit and its clinical significance would be of value. I would like to thank the UW Alumni Association for the funding that made this project possible, as well as to my wonderful committee for all their guidance throughout this process. I would also like to thank the UW Ortho team and clinic, all our faculty, and my amazing group of co-residents who have made this experience really quite amazing, as well as my family and my husband. Are there any comments or questions that I could help answer?
Yes, there is a question from Nanhaj. Interesting project and great presentation. Do you know accuracy and consistency of your intramural scan interarch occlusion versus true patient occlusion?
No, we don't have any data regarding that. Currently, there is a PROS resident who is looking into doing a study regarding that. Previous studies have shown that they are pretty accurate. However, studies haven't necessarily compared occlusal contacts like taken with shim stocks and articulating papers to those taken with iTero scans. So future studies looking into that would be interesting as well.
Okay, thank you very much. So I think I'm gonna, because of the time, I'm not gonna take any more questions, but I will invite Dr. Anne-Marie Boland as the discussant of this project. Anne-Marie.
Thank you, Burju. Gabby, I'd like to congratulate you on a wonderful project. And in a way, the results were not as exciting as we were hoping. I think we all as orthodontists hope that we move teeth and we provide patients with a better occlusion, meaning teeth fitting together. But I don't think we should be that surprised that when we move teeth around, the occlusion kind of changes. And people do mention that their teeth feel weird. They don't quite fit as tightly together. And as you mentioned, one of the limitations is that you did not look at settling, which people have shown really increases post-treatment occlusion. So the teeth do start getting to fit together better. Similarly, like you found, younger people have less tight contacts than older people. As we use our teeth kind of grinding and eventually kind of come together in a better fashion. So I don't think we should be too worried that we're messing up people's occlusion. Also, when you're looking at your contacts, they are basically just distances between the upper and the lower teeth in a specific area, 0.1 millimeter, 0.2 millimeter. I think we could still have food boluses, food particles come between the teeth and crush them properly, especially if we eat a diet that's not hard rocks or some kind of bark that we're needing to crush. So I think one limitation that you also mentioned is that we have not really looked at what these contacts mean in terms of ability to chew and eat our food. And there were a whole bunch of fun studies in the literature that have looked at how much patients can chew different foodstuffs by giving them those food items and then having them chew around and then look at how small the chewed particles become. So there is a lot of research to be done in that area, but you have put a tremendous amount of work in getting that first step going, and really I have enjoyed tremendously working with you, Gabby. You were a joy. You worked very hard on your own. There were a lot of stumbling blocks. I don't think people realize how many hours and hours you spent. As with all research, there is step backs. There is times where you were very sad. Things didn't work out and you had to start everything over from scratch, which you did with a smile on your face and spent another 100 and 200 hours looking at different teeth and measuring it and coming up with the great results that you did. So I'd like to present you with the long-awaited certificate, and congratulations, Gabby. We'll miss you. You were a great asset to the program, and I've certainly, and I think we all have enjoyed having you around. Thank you.
Thank you, Anne-Marie.
Okay, thank you, Anne-Marie, and congratulations, Gabby. Now we'll move to our next presenter, who's Sarah Overt, and she will be talking about the bias and superimposition of lateral cephalograms in anterior open bite patients. Sarah.
Hello, everyone. Oh, sorry. Okay, should be better now. Hello, everyone. Thank you for coming. And I would like to present my project, which was bias and superimposition of lateral cephalograms in anterior open bite patients. So here are 3 patients with an anterior open bite. So as you can see, the common like tie between them and the common reason for an anterior open bite is just like it sounds. The front teeth are open and not touching. These patients are all very similar, but they're all treated with 3 different methods of treatment. So the first patient was treated with braces. The second patient was treated with clear aligners or Invisalign, if you've heard of that instead. And the third patient was treated with braces in conjunction with TADs. So all these treatment methods are very different, and the mechanism could be different or the same, depending on what your thoughts are on how each of them works. So my study kind of diving into these things a little bit deeper. So fixed appliances or braces can be used to extrude the incisors, usually due to elastics. One downside to this is that if the patient starts with a gummy smile, then it'll get gummier after more extrusion. So premolar extractions can also be paired with fixed appliances to allow retroclination of the anterior teeth and closure of the open bite through the drawbridge effects. One technique that uses fixed appliances is the meow technique. And this one is to control incisor extrusion and promote molar intrusion. And so this is an example of what that would look like in case you're not familiar with that type of wire. So this top arch wire where there's all the loops inside of it. So on the other hand, clear aligners can be used to treat anterior open bites, and the claims are that they're as effective as open as fixed appliances, and that you're getting an intrusive force in the posterior teeth due to a double layer of thickness of plastic between them and then the patient's bite and chewing force. Another advantage is you have virtual treatment planning with the ability to selectively move teeth and ideally prevent incisor extrusion. On the other hand, current evidence is stating that primarily incisor extrusion is what is actually closing the anterior open bite rather than molar intrusion, and that is actually very minimal, and that there really isn't a significant difference between treatment and clear aligners or braces. So TADs, which are skeletal anchorage, can be used with the hope to intrude, they can intrude posterior teeth, and the hope is you're decreasing anterior facial height through rotation of the mandible. However, current evidence does show that molars can be intruded, but the mandibular plane change is really reported inconsistently. So how do we know what dental and skeletal changes are actually occurring with these different treatment methods? So we use superimpositions. Superimpositions are x-rays from the side of the head where we'll ID landmarks on them and then trace structures. Then you take the final tracing and overlay it over the initial tracing and aligning those structures, and you can see where the changes are occurring. So there's several reasons that you may get error in this in doing a superimposition. One is the projection you can get when you're obtaining the x-ray, and you might also get error in identification of the points. Another component that might be affecting the resulting superimposition is the possibility of practitioner bias. And so that is really what our study sought to find. And there is a quote that well fits this our hypothesis. John Artoon was a faculty at UW in the 80s and 90s, and he has been known to say, tell me the treatment a patient received, and then I can perform a superimposition showing the changes that should have occurred. So this is the very thing we decided to look at in our study. Primary aim of our study was to evaluate potential effects of bias in manual superimpositions when the practitioner was aware of the type of treatment provided. A secondary aim was that we compared these findings to the changes measured in the cephalometric values of the patients we were assessing. So how did we do it? We recruited our raters in the summer of last year. We had 6 graduate students, all after completing their superimposition course, all of which were female, just due to our classes being only female for those 2 classes. And we also recruited 6 orthodontic practitioners that were greater than 5 years out of school, and 3 of them were male and 3 were female. We used 30 pre and post-treatment lateral cephs from a database we already had at the UW. 10 of the patients were actually treated with fixed appliances, and 10 were treated with clear aligners, and 10 with TADs and fixed appliances. One example can be seen on the left. All of the patients were adults and non-growing. All their images were imported into Dolphin, which is our imaging database, and landmark points were identified, structures were traced, and then we removed the actual image of the x-ray to make it less identifiable by our raters. And then we captured measurements from the Dolphin software based on these tracings. So the 30 tracings were duplicated into 3 sets, A, B, and C, each of which was randomized within the set, and there were 5 duplicates selected that would later be used to assess inter-rater reliability. The students and practitioners were then grouped into 6 groups, and this determined which order they would see the sets in their sessions. So we had 3 tracing sessions. In session 1, consent was obtained from our raters, and we also got a brief survey obtaining demographic information as well as their methods used for superimposition. At this time, they were told all the patients were treated with fixed appliances and asked to complete the superimpositions. 1 month later, during session 2, they were then informed the same patients, they didn't know that though, was that they were clear aligners, treated with clear aligners, and the last month they were told all the patients were treated with TADs. So during the initial session, all the raters were informed that deceptively that the goal of our treatment or our study was to look at reliability of superimpositions, and this way it would blind them from the actual goals of our study. So the data that was gathered was a PDF image of the completed superimposition in Dolphin. An example is on the left. You can see the initial tracing was in black and the final is in green. When I pull up these 2 tracings, the rater had the ability to freely position the final tracing over the initial tracing in whatever fashion they deemed satisfactory. And at that point, then I captured the image and saved it to evaluate later. So the primary outcome that we assessed was the mandibular plane angle. And the way we did this was we looked at the anterior portion of the mandibular plane of the first and second tracing. And so you can see in this example, since the green is higher than the black, we would count this as closed. If they were aligned or touching, it was same. And if there was clear distinction and it was below, then it would be opened. These ratings were then converted into numerical values. So what did we find? We can see the demographics of the students on the left and the practitioners on the right. And the practitioners had an average of 16 and a half years in practice, between 6 and 30, so quite a range. All residents were in their 3rd year except for 2, which were in their 2nd year. All residents, of course, were from University of Washington, but there's quite a variation amongst the practitioners. The method for superimposition was much more agreed upon by the students, but there was some more variability in the practitioners. While most people did use the cranial base at anterior sella as their reference point for doing their superimposition, the practitioners also each had one person that used a cranial base with cranial fossa structures, one person used a Selenasian line, and one person used best fit. So to look a little deeper at our results, here are the results from the graduate students. To orient you to the table, we have the columns, which are session 1, 2, and 3, where they were told fixed aligners and then TADs. The first row is when their superimposition showed opening with the mandibular plane. The middle column shows when the mandibular plane was the same, and the bottom shows when the mandibular plane was closed. So we also compiled the same table for the orthodontic practitioners. Now, to compare the results, we can see that the graduate students on average said that mandibular plane was the same in all of their superimpositions more often than the practitioners. On the other hand, the practitioners tended to show a little bit more mandibular plane closure overall than the students. The graduate students had the most closure in session 2, whereas in orthodontic practitioners, session 1 and 3 had slightly more instances of mandibular plane closure. However, none of these results or differences were significant, so these p-values were all insignificant, and this is comparing session 2 to session 1, and then session 3 to session 1. If we combine the results, there still wasn't any significance between any of the sessions. Mostly we saw superimpositions with mandibular plane angle being the same, followed by some mandibular plane closure. The only trend that we really saw was that over the 3 sessions, there was a slight decrease of superimpositions showing mandibular plane opening. However, this was not significant and only very slight. So unfortunately, if we had given John Artoon the name of the Artoon effect for bias in superimpositions, we would not see an Artoon effect observed in our results, unfortunately. But what we did see is some real variability, and I said we used the duplicates to look at inter-rater reliability. So overall, the agreement was 68% for the duplicates within each session for each individual rater. Cohen's kappa coefficient was used to assess this, and we had an unweighted score of 0.5, weighted of 0.6. Both these values are considered moderate agreement. The inter-rater reliability, so looking at rater to rater, the interclass correlation coefficient was used, and the values for session 1, 2, and 3 were 0.7, 0.62, and 0.69. So all very similar, though slightly increased in session 1. And again, all of these were of moderate agreement. So looking back at the combined results table, as I said, we didn't see any bias, but we did see some variability, which you really can't appreciate in this table. If you look closely at the 3 values over the 3 sessions, they're all pretty similar. But they were only agreeing with themselves about 68% of the time. So we looked a little more deeper into the variation, and we came up with some examples to illustrate this. So the first example is the variability between sessions. In this example, we looked at all the raters' results for session 1. We totaled up how many times there was mandibular plane opening, closing, and staying the same. And then we looked at how many times this result changed in session 2 within that patient. So in session 1, if they showed opening, did the next time they show closure or the mandibular plane being the same, and so on and so forth. So if we look at those results, this table is showing that. So in session 1, we have our totals here with mandibular plane angle being the same, open and closed. Then we looked at the number of times that they changed and then how they changed. So for session 1, we had 144 superimpositions showing that the mandibular plane angle was the same between initial and final. 42 of these changed, and of the 42 that changed, it was almost split in half, which ones showed opening and which ones showed closure. 102 of them were exactly the same the second time. If we look at superimpositions that showed opening of the mandibular plane, there was 90, which was the least of the 3 groups. 21 of these changed, which is about 23%, and only 4 of them went in the opposite direction. So instead of showing opening this time, they were showing closure. And then for those that started with mandibular plane closure in the first image, the second time, again, only 23% showed change, and this time only 2 of them showed the opposite jump. So the second example is looking at intra-rater agreement. So looking within one rater, how many times with themselves over each session. So for example, if this is rater X, and this is patient Y. In session 1, 2, and 3, they had the same resulting superimposition. So how many times did this occur? This table illustrates that. We have the graduate students on the left and the practitioners on the right. And it was out of a total of 30 possible times they could have been correct. The highest agreement was 83%, with 25 out of 30 being of the raters agreeing with themselves. This was one student and one practitioner. On the other hand, the worst reliability or agreement would have been 13 out of 30 times, or 43%. And again, one graduate student and one practitioner show this. So there's quite a bit of variation. And overall, the average was 63% of agreement, but quite a range when you look between 43 and 83%. The third example was looking between the raters. So in this example, we looked at how many times did everyone agree on a patient within one session. So in session 1, for all the raters and patient X, did they have the same resulting superimposition for each rater? And this happened 9 times in session 1, 4 times in session 2, and 5 times in session 3. So it was most common in session 1 with 30% and slightly less in session 2 and session 3. On the other hand, we looked at how many times was there disagreement on a patient. So was there at least one instance of an opened, closed, or the same superimposition across all the raters' results? So again, session 1, all 12 raters, patient X, how many times do we see one of each? So this is an actual example of one patient's results where 3 people said there was no change in the mandibular plane, 3 people showed it was closing or opening, and 6 people showed closure. This happened about 30% of the time in each of the sessions. We also acquired the cephalometric measurements from Dolphin of all the initial cephs, so we could compare how similar the patients were to each other before treatment. Overall, to summarize this table of many numbers, everything was about the same except for 2 categories where the group of patients actually treated with TADS had a slightly lower mandibular plane angle than the other 2 groups, and in addition to, they had a least severe open bite than the other 2 groups. So to look at the actual change between the initial and final measurements, we used an effect size calculation, and the equation is seen here, and effects of greater than 0.5 were considered moderate, and anything greater than 1 was large. So a table to summarize the effect sizes on the left, and highlighted here, I will show you some of the significant outcomes. So large effect size outcome was seen in overbite across all the categories. We also saw a large effect size in the angular change of the upper and lower incisors in both the aligner and TAD groups. Moderate change was seen in the millimetric measurements of upper and lower incisors. And there was non-significant or minimal effect seen in millimetric molar measures, so vertical change in molar or skeletal categories, so your anterior facial height or mandibular plane angle. So why didn't we see bias? We received the raters from the actual goals of the treatment. So when we told them that we were looking at the reliability of superimpositions, the raters could have been just trying to complete the task correctly. We didn't ask the raters to assess what they did or what their superimposition showed. And as well, the raters had less reason to be biased because they weren't involved in the treatment of the patient. They didn't have any desire to show any particular outcome. They probably had less investment in showing what they wanted to see or expected to see. There were some interesting anecdotal observations, though, that I made during the tracing sessions. The first statement that someone made was the superimposition could have been done differently depending on what you think the treatment results were, which is somewhat similar to what John Artune was saying in a different sense. But this really supports the fact that superimpositions don't have a single answer, and there really is probably a range of what could be considered acceptable amongst different practitioners. This also suggests there may be potential for subjective bias that we didn't fully explore in our study. And another thing that was said amongst many of the raters during the last session was this group is harder to superimpose. And so it seemed to everyone that when I told them they were all receiving treatment with TADS, that the task was much more challenging. And this could be because the true mechanisms of TADS effect on the dentition is less well known, Or it could be that there's some possible subjective bias that we didn't fully explore, because again, we weren't really asking them to assess what they did, we just asked them to complete the task. So while we didn't see any bias, we did see a fair bit of rater reliability and variation amongst the results. So overall, it seemed that the raters had better agreement in patients where there was clear mandibular plane opening or closing. In instances where the patient may have had minimal change in the mandibular plane, and this is where we saw a lot more variation amongst the raters' results. And overall, the reliability was about 68% across their repeating of the duplicates. So at best, 7 out of 10 times they were agreeing with themselves, but they were still coming up with a different answer a significant portion of the time. So looking at the cephalometric measurements, based on our small sample of patients, each with only 10 in each group of treatment methods, we saw the greatest change in overbite and incisor position. So it appears that appliances have little effect on the mandibular plane or skeletal components. And this is consistent with previous studies, 3 of which I have listed here. So as with every study, our study did have some limitations. The groups did have some initial differences. Most notably, the TAD group had a lower mandibular plane angle to begin with and the least severe open bite. The raters were not asked to evaluate their superimpositions, and so we really fully didn't explore the potential for subjective bias. We also deceived the raters from the actual goals of our study, which may have led them to try to complete the task correctly. And our results were limited to only adult patients because that was the patient population that we looked at. So the strengths of the paper is that we did use adult patients, which removes the potential for error and bias due to growth, because there can be a great effect introduced when an adolescent patient is growing or you're using skeletal modification. So we removed that aspect of complicating the results. The raters were blinded to the actual treatment rendered to the patients themselves, which does remove some of their influence on a certain outcome, but on the other hand, could have been removing our potential for subjective bias. And what's really most important and the strength of this study is that it is one of the first studies to investigate operator bias in completing manual superimposition. So from what I could tell, I couldn't find any other studies looking at this. And I feel like this is a really important aspect to acknowledge when you're looking at a superimposition in another study, because a lot of times we're relying on other people's papers that are published and they're supporting their claims with a superimposition. So it's good to consider the fact that there may be some bias in influencing what they're showing. So in conclusion, we didn't find a high degree of superimposition bias. There was significant inter and intra-rater variability, and the variability in superimpositions may lead orthodontists to make differing conclusions on the same tracings, depending on what they are intending to show. The anterior open bite was corrected primarily through dental movement, at least in our small population of cephs that we looked at. So I'd like to thank the University of Washington Alumni Association for their support for this project. I'd also like to thank my committee, Greg Long, Jeff Greenlee, and Brian LaRue, as well as the faculty and students that participated in my study. I'd like to say a big thank you to my support team. First of all, my co-residents that I actually have really enjoyed spending so much time with. That came out wrong, but we all get along so well, and I'm so blessed to have such a wonderful group of friends. We've had a lot of good times. We've eaten a lot of ice cream, and I can't thank the rest of all the other residents as well, and the other classes, as well as our wonderful staff and faculty. We have so much fun, even during COVID, when we had to wear a mask, we could still have fun. And I don't have pictures of everyone, but everyone who's gotten together, and we've all made enjoyable times out of such a crazy year. I'd also like to thank my previous roommates and friends that have been with me since my beginning of time at UW, and now it's my 11th year at UW, and they have been with me through it all, so I feel like they deserve honorary degrees as well. And I'd also like to thank my family. First of all, my husband, Tyler, and my cat, Cisco, who spent a lot of time with me during quarantine. And And my family, all these are from dental school graduation, but we're pretending it's today. So my grandma and my parents, my brother, my aunt and uncle, my great aunt, uncle, and cousins. I'd also like to thank my mom, who's not here today with me anymore. But I know she'd be so happy. I'm sorry. I didn't mean to cry. But she was always my biggest cheerleader to get me to this day. So I just wanted to say a special thank you to her too. And thank you, everyone.
Thank you, Sarah. Good job. And there are some questions for you. So let's see. Ruse is asking, did you look at cases with various reports to see what could potentially result in maybe quality of the ceph or specific skeletal pattern? Great presentation.
Okay, let me see if I understand the question. So did I look at studies?
Ruse,
I'm not sure I fully understand the question.
Yeah, are you seeing the question? Ruse, did you want to clarify?
Yeah, so when you showed some of your cases are not reporting the same mandibular, opening or closing.
Yeah.
There are certain cases that they go, one versus the other direction, but the direction is the same. So the question is that, is there any reason that you looked at either the quality of the records or pattern of the skeletal pattern of the patient that caused this discrepancy? Even that the good news is that it's in the same direction, but I'm curious to see like what causes that. Have you looked at it? And I know it might be very hard. So just your thought about it.
I'm still not sure I totally understand, but no, we didn't really look at like cases. Like we tried to break down our instances where it was just categorical of open, closure the same, but we didn't really categorize any chance where it was open and the second time they opened more because it just added too many like variables. Is that
so what do you think that caused that the second time showed a little bit more?
I think the biggest factor is just sorry?
Is it just the personal error, like the measure, like the identification or landmark error, or you think that just the ceph had a specific quality or the patient looks in any specific skeletal pattern that caused that?
I think there's a couple things. One, I think there's just some variation in like the rater themselves. And then two, I think it's because these cephs, like we try to find the ones with the best quality pre and post treatment records, but there is some variation in like the magnification between the two x-rays. So, and like that can influence like how the two ceph tracings look, which could then influence how they're trying to make them line up, because if the magnification is not the same, there's going to add that like variability too. So I just think like there's a lot of variation within the like creating the tracings before you do the actual superimposition that could be affecting how you end up you're doing your superimposition in the end. Did I get it?
Yes.
Okay, good.
Sarah, there's another question from Mike Harefield, and I will try to summarize it as, what made you suspect that knowing how the result was achieved using a particular treatment might affect the behavior of tracing the ceph?
Well, Greg has the story about that happening with talking to somebody who wrote a paper and said that they showed mandibular plane change, but then their ceph in the paper didn't show it. And he was talking to them and they said, oh, you should have reviewed the paper and then I would have changed my ceph. So that kind of like triggered the whole thing. But then when I was like working on finding like any, like just learning about like bias in superpositions and et cetera, I'm actually found like some psychology papers, and there's something called the Rosenthal effect or the Pygmalion effect. And that is when you like do something a certain way because of what you expect it to be. So like your results might be influenced by what your expectation is for the outcome. So that's kind of supported our further investigation of this.
Okay, one last question from Richard Garfinkel. Can tracing and superimposition be done digitally? Eliminate human errors and bias. I'm assuming, like, talking about it totally being everything.
Yeah, there are some ways, and I did see a few papers like talking about the benefits of like having a computer just recognize the points or do the tracing. And you can also just like pull the measurements and then subtract beginning and end. So, and there's also a paper discussing kind of the benefits of the visual manual superimposition versus just the like numerical change. And there is like definitely it's more sensitive to look at numerically. However, it might be like too sensitive. So like having the visual superimposition, and I'm not sure 100% if there's like software that can do the overlay superimposition perfectly. But when you do it in Dolphin, you can set it to a variety of points that it can use as a reference, but I'm not sure there's anything like there that's as good as humans quite yet in terms of the visual representation of a superimposition.
Okay. Thank you, Sarah. Now, I would like to invite Dr. Greg Huang to make a few comments about this project. Greg?
Yeah. Thank you. Thank you, Burju. And thank you, Sarah, for really all your hard work and efforts. I think this is a very provocative topic because it kind of gets right, to the meat of our specialty. We all like to say, I treated this patient and here's how I fixed the malocclusion. I treated this patient and here's how I fixed the malocclusion. And to show you, I will present my superimposition. And so it's a little bit worrisome to us that perhaps these superimpositions could be subject to our personal biases, right? And so yeah, I understand this potentially can make us feel a little bit uncomfortable. We undertook this project to look at this potential bias, and we used the deception that it was actually going to be a study looking at reliability. And ironically, much to our surprise, in this sample of 12 people, we didn't see a lot of bias. And, we have our reasons for hypothesizing why that's the case. But then what we realized is we saw a pretty significant amount of variability. And so it kind of came back to the deceptive reason we gave almost became what we wound up investigating in retrospect, right? So I think the real gist of this project is that in patients whose mandibular plane doesn't change a lot with treatment, and in fact, that's probably the majority of our patients, right? We probably aren't able to influence the mandibular plane that much. And so if we think that's the majority of the patient, what this study kind of tells us is that probably people who are treating these patients could make superimpositions that show the whole range of outcomes. They could probably show the mandibular plane changed none, or that it closed, or it opened. And so we probably need to be really careful when we're reading studies if authors are reporting to us that we used XYZ technique and we showed that the mandibular plane changed 2 degrees. That may not really be a very compelling difference, especially if they're basing that on their superimpositions. Now, I'm glad Rick asked his question about using automated measurements. And I think that really is a good idea. And in fact, that's what Sarah kind of used as her secondary aim, to look at these cephalometric measures. And if you recall, what those measurements told us was that most of the action was in the incisors, okay, retroclining and extruding. And we had really almost no movement of the molars vertically we had almost no movement of the mandibular plane. We had almost no change in the anterior facial height, right? So I do strongly believe that we should probably try to pick our landmarks as well as we can, and then rely on automated software to spit out our cephalometric values. And that might be a lot less biased than the wiggling and the jiggling that we do when we perform our superimpositions. Okay. So again, Sarah, congratulations on a project really well done. You've been a great resident. Thank you very much. Amory's gonna give you your virtual certificate, right?
Yes, I do have it, Sarah. Is that number 4 from UW? How many have you gotten now? 3. Well, this is most likely the last one. You've
My dad
it.
said I should keep going.
You definitely earned it. Congratulations. You
Thank you.
are a true husky, and we'll miss you too.
Thank you. Go Dubs.
Congratulations.
Do we reconvene? We're really not very far off on our time, but why don't we reconvene at 11:30? Okay, let's just take a short break.
You mean 10:30?
10:30. 10:30.
10:30.
10:30, okay? All right.
Hello, everyone. It's 10:30, so I think we should get started with our next two presenters. Our next presenter is Lee Armijo, and her title is Use of In-Fiber Bragg Grading Sensors to Measure PDL Strain in an Ex Vivo Swine Model. Lee?
Hello. Hello. So for today's talk, we will be discussing the topic that Virju just mentioned. So for some background, this is a schematic of a tooth for those who may not be familiar. The tooth with the crown and the root is housed within an alveolar bone support, and in between the bone and the tooth, there is a space called the periodontal ligament. Within this space, there are many different components that you can see zoomed in here. It's composed primarily of collagen type 1 and type 3 fibers, surrounded by an extracellular matrix that has multiple different cell types, 25% of which are fibroblasts. Previous in vitro studies have shown that these specific cells are strain sensitive and can respond with varying expressions with different rates of growth factors dependent on the strength of the mechanical strain that is being induced on the tooth. The fibers, primarily collagen, can also be stretched and compressed with load, as these are constantly changing and occurring in this area. This space is very small. In humans, it's about 0.15 to 0.3 millimeters. And in pigs, it's a little bit larger, can be up to 1.6 millimeters. This varies depending on the age of the tooth and also our age and of the specimen and how often the tooth is being used. Because of the small size and the complexity of the different components, these characteristics make it difficult to assess the changes that are going on structurally when a load or strain is being put on this particular area. So an overview of orthodontic tooth movement. As we know, when a force is being applied on a tooth within that direction, you have compression occurring where bone is being resorbed by osteoclasts. And on the tension side, where the tooth is moving from, you have osteoblasts filling in this void. The PDL also at the same time is remodeling. Every individual is unique. The amount of fluid that's within this space, the fiber content, cellular content, the density of the bone, the stress and relaxation of the fibers and the changes are all responsible for the movement of the teeth within this bone and can therefore be responsible for the differing responses that we see in every individual, such as the amount of time needed for space closure or ease or difficulty in derotating a tooth. While orthodontics aims to result in an ideal aesthetic result, there are some negative effects that can happen. One that isn't uncommon is external apical root resorption seen here. This is pre-ortho and post-ortho, as you can see the blunting of the roots. These teeth can also become mobile and in very extreme cases, if you have extreme bone loss and in conjunction with periodontal disease can lead to tooth loss. This external root resorption is multifactorial. Many things do contribute, such as increased treatment length, specifically intrusive forces, heavy continuous forces, and an individual's genetic predisposition. This particular study is a way to try to better understand the amount of force that is required for particular tooth movements and the strain that is induced on a tooth within the PDL space to try to limit these potential side effects that can happen. So in this study, we are using a swine model. Here is a picture of a pig. While using human teeth would be ideal, we do need to understand the use of the tool that we are using, this FBG sensor, in a pig model before we can use it in humans. Pigs have been used in the past frequently as they have a comparable growth pattern to humans. They have similarities in physiology of mastication and jaw movements. You can see the upper and lower jaw here. They have the incisors here in the anterior part that are used for cutting, and then the premolars and molars in the posterior, using for grinding, similar to what we do for function as humans. They are also easily obtainable for research. In this particular study, we are focusing on the incisors, so the anterior portion of the jaw, specifically the central incisor labeled I1 here. As future in vivo experiments, these particular teeth are the most accessible. So our semi-novel tool that we're using to measure strain is called an in-fiber Bragg grading sensor, shown here. This is the portion that plugs into a specific unit, and the very tip of the fiber is the actual active portion. So these sensors were developed in the 1970s. They have been used in multiple industries such as automotive, telecommunication, and others. They are unique in that they have intrinsic capabilities to measure multiple parameters such as temperature, pressure, and in our particular study, we're looking at strain. They also have been used in previous biomechanical areas such as pressure mapping in orthopedic joints. And our collaborators in the University of Alberta a couple years ago have shown that they have been able to see repeatable strain measurements within the PDL using these sensors. So these sensors are very small. They are coupled within an optical fiber. And so when light from a broadband source is reflected on here, it reflects the portion of the light to a FBG sensing unit, which is then measured by an optical spectrum analyzer. Here's the diagram. And when the FBG is subjected to some type of change in its environment, it causes a shift in this wavelength that is picked up, and it can be changed to microstrain by a conversion factor. Like I said, the tip is the only kind of active component of the sensor. It is very small, measuring 1 millimeter in length and 0.125 millimeters in diameter. Its small size is kind of the main reason why we are hoping this can be used to better understand what's going on in the PDL as it can fit into this space. So our specific aims are to look at strain. And when I say strain, it's basically a deformation or a change that's occurring within the periodontal ligament space when we are applying a specific force. So our first aim is to use these sensors when changing the fluid environment within a tooth of a pig housed within its alveolar complex. Our fluid components are either doing it dry or adding saline to the specimen. Our second aim, which was all data collected by a dental student who helped me, using the same sensors and the same specimen of teeth within the alveolar bone, but changing the fiber content by looking at the specimens in saline, and then following with a fibrotomy of the gingival fibers and a collagenous incubation injected for depletion or reduction of the collagen fibers. So this is a picture of kind of my setup. Here is the Smart Scan, which is the optical spectrum analyzer. These green parts are the inputs for the fiber optic sensors that the other end is placed in the horizontal ligament space. All of this data is relayed to the computer here, and we use a MATLAB software to compute all of the data. Here on the left, you can see this is our MTS material testing machine that we are using to apply a load to the tooth. Our collaborators in Alberta made this mounting stage for us so it can be adjustable. And then these screws are used to hold the specimen in place. Here is our loading platen that we can then use to apply an intrusive load on the tooth. Here's a schematic of what this fiber is doing. So using a 27 gauge needle, I'm placing it within the PDL space between the bone and the tooth, and threading this small fiber within the needle so that it lies here within this space. Here is a photo. These two are the central incisors when available. We used both incisors. Here's the predetermined mark for how deep I put the fiber in for each tooth, and it was mounted in plaster and held secure by the screws in the loading mounting stage. So for our sample size, we obtained all of these pigs from the UWOAA Paramedical Training Center on campus with an approximate age of 2 months. So they're all in the primary dentition. All of these younger animals were used for the dry versus saline condition. So we had 19 total incisors. For the saline and collagenase condition, looking at the different fiber content, we started using the younger approximate 2-month age samples, but unfortunately after the collagenase incubation, because the animals were pretty small, the teeth often became very loose and unstable. And so getting the second reading after the collagenase was not always possible. So we did switch to a larger specimen of approximate 4 months age that we obtained from a local butcher. And those were much larger and more robust animals, and so therefore were able to give us better readings. Our sample size was determined to have 16 incisors for 80% power. So the driver saline group has an adequate sample size, but the saline first collagenase is underpowered. Because we are using the younger and the older group for the saline and collagenase group, we did look at the repeatability of measurements between the older and the younger groups to make sure that we could pool the two different age groups. And so while we're still underpowered, we do have 11 instead of just using the younger or just the older group. Because there were also 2 examiners, I did the dry and saline, and the dental student helped me with the saline and collagenase. We also looked at our repeatability, looking at just the saline group, because that was the only group that we both did those same tests on. And we looked at the deviation from the median, and there was no difference, which we used to show that our technique can be repeatable. So our results, so just a quick overview of what I did. So for the driver saline test, we used the younger group specimens, and I used that sensor and I placed it within the PDL on the lingual side to a predetermined 10mm depth. Every tooth from the MTS machine was induced a 0.5mm intrusion and held for 10 seconds and repeated 15 times. And when available, the right and left incisors were used for both, resulting in 19 total incisors from 10 different pig mandibles. This is an example of our MATLAB graph of the strain and force readings. Here, the red stars indicate the peak strain from one given trial, and there were 15 total for each tooth. You can see there is a consistency in the trend between the dry and saline, indicating fiber was stayed in the same spot between both testing conditions. These trends vary greatly, incisor to incisor, depending on the position of the tooth relative to the loading platen. So of those 15 trials for each tooth, we took the median of the peak strain because there were some outliers, which are indicated here. Red is dry, blue is saline. So for each individual tooth, we then subtracted the difference between the dry and saline peak strain values. For this particular group, there was not a statistical difference. However, the confidence interval upper bound is somewhat close to 0. So this may show that saline could have a higher strain value compared to the dry, which could be explained by the presence of fluid, allowing this fluid flow within the collagen fibers, creating a greater strain difference, a different environment within this PDL space, but it's not statistically significant. Looking at the force values between the two, there was no statistical difference noted between the dry and saline conditions. The second condition we used, were comparing these teeth undergoing a saline or collagenase environment. For this, we used both the younger and the older age specimens. The fibers were placed to the same depth of 10 millimeters on the lingual side, and the same 0.5 millimeter intrusive load was applied by the MTS machine, held for 10 seconds. The main difference between this protocol and the last was because we had to remove the fiber to perform the fiberotomy with the scalpel and inject the collagenase within the PDL space and incubate it. The fiber optic sensor was not necessarily placed in the exact same position from the initial saline test, which can lead to variability in our strain readings. And then due to limited sample sizes, we only have 11 incisors from 8 pig mandibles. This is an example of the MATLAB readouts of the peak strain values for the saline collagenase from one single tooth. This was a consistent trend, seeing a switch from compression, having positive strain values in the saline condition, to negative tension values in the collagenase condition, which can be explained because we are removing or depleting some of the collagen fibers. The tooth changes its position within the bone and is more loose. So therefore we might be getting more tipping as opposed to relative or actual intrusion of the tooth. So looking at the strain values, to the left of this dark line, these are the younger specimens, and to the right are the older specimens. Blue is the saline, and then red is the collagenase treated. You can see that there was a difference. We had a negative value of difference of peak strain, meaning that the saline group had greater strain values. This may be explained by the fibers being intact and present. They help transmit the forces applied to the tooth. And with the fluid and the fibers present, it creates a greater interference with the collagen as opposed to just having fluid flowing in between the space. Looking at the force values for these two different conditions, there was no statistical difference. Lastly, we looked at the trends of the force values between the varying conditions. These graphs are very confusing and look like a mess. It basically is plotting every 15 trials for every 19 of the incisors that were tested. We used a lowest smooth graph based on all the trials, and is used to compute the summarization of the trends, which is shown in blue, and a confidence interval band, which is shown in this gray area. So for the dry, there was no change. It was relatively flat. However, for the saline, there was a noted linear downward trend for the saline. And then looking at the saline collagenase, you can see both have this downward trend that was significant. This may be due to fatigue in the PDL, as we are applying a load 15 times repeatedly on each incisor. We do have a wait time of 5 minutes between each trial, but this may not be enough time to allow full fiber recoil and relaxation to its original position, and or not allowing the liquid to kind of migrate back into this PDL space. We chose this 5 minutes kind of as just a standard to keep it consistent between tests. So maybe holding it longer would have brought the teeth back to more of its original position. This could be significant though to us orthodontically if we know that this downward trend is happening with intermittent forces, that we may need less force over time to result in the same desired movement, therefore decreasing potentially unwanted effects. This test did have some limitations. We were using an ex vivo model of these swine teeth. So we can't actually know what the proteoglycan content is or molecular weight of the components within the PDL and all of the changes that are actually happening in an in vivo environment. It's also pretty difficult to determine the long axis of the tooth when I'm placing these incisors relative to the loading platen with the curvature of the root and not having a 3D image of the tooth. I am doing a best guess estimate of where this tooth should be the long axis. And it has been shown that changing the orientation of the tooth can greatly vary the strain readings. So there is no standard to compare to, therefore all the teeth were treated independently and compared independently between the different conditions. We also, for the saline and collagenous test, the fiber was moved between the two different testing conditions, which could also affect our strain readings. These swine teeth, the premolars and the molars are more anatomically similar to our human teeth, but due to accessibility of the incisors, we use those, so the comparison is not as great to human teeth. We also have the small sample size for the collagenase treated group, and we only looked at an intrusive load as opposed to other extrusive lateral rotational changes that occur in orthodontic movement. So in conclusion, we were able to use these sensors in an ex vivo model to measure strain when we applied a load to the tooth. We did see that the saline group had a greater strain readings than the collagenase, whereas the dry and the saline did not have a statistical significant difference. And lastly, there was a downward force trend for both the saline and collagenase specimens. Therefore, changes are occurring when these fibers and fluid flow is able to change. Future applications are going to use this fiber optic sensor in an in vivo environment. Whether it will be used in a human model is unknown at this time. Kind of need to see how it will respond in the swine model. So clinical significance may not ever be there. Our PDL space is much smaller than the pigs. So while I was able to readily place this 27 gauge needle within the space, doing that in a human tooth, I don't think really will be possible. So this is more for us to understand kind of what is happening within the PDL space to understand the mechanisms that's occurring as opposed to kind of using it clinically. I would like to thank Dr. Popowicz, my thesis advisor, for all her help and guidance with this project. Isabel is the dental student that helped me gather our collagenase data. Kate and Dan are our collaborators from the University of Alberta that helped a lot with the protocol development. Lloyd for his statistical analysis, and the other members of my committee, Sue, Kathy, and Anne Marie. I'd also like to thank the UW Ortho Alumni Association and the AOF for their funding. Also like to thank all of the faculty that come to see us every week and help us in our education, and all of our clinical team members who help clinic run smoothly. Without them, we wouldn't be able to see all the patients we have been, especially during COVID. These are our citations. Any questions?
Thank you, Lee. So I did see one question, 1 second. So it's from Mike Harefield. Since water is incompressible, let's see, were you absorbing fluidic, hydrodynamic, or hydraulic effects from the saline? Do you have a mathematical model to explain or predict what you observed in the PDL space?
I do not. I'm sure there are some pressure effects to having the saline on the tooth when we're intruding it, but we don't have any model to kind of depict what changes that can cause in our strain readings.
Okay. And this is from Tyler Overd. He's saying, maybe I missed it, but was the gauge zeroed after each load or once at the beginning of the series?
I'm not sure what the gauge he's referring to. I mean, the same sensor was used for each tooth.
Strain gauge.
I mean, the same sensor was used for each tooth, and then we allowed things to relax, and the load was taken off the tooth. I'm not exactly sure what his question is.
Would you like to clarify, Tyler?
Sure. I'm just curious how the strain, if you're only applying a load and you're measuring strain, you didn't do that with a strain gauge, you just did that with a load gauge?
We use the fiber optic sensor. It has the capacity to measure that. And then we use a formula to calculate the microstrain based on the output from the optical spectrum analyzer.
Okay, was that zeroed at the start of each load, or was it zeroed once at the beginning?
I mean, it went back to baseline after we removed the load on each trial.
Okay, so you didn't manually zero it, it just sort of zeroed itself as the tooth moved or readjusted?
So, I mean, I applied a load and then it did its reading. And once I removed the load, then it zeroed back out to its original position. I didn't manually do it. I mean, I removed the load and then the fiber optic sensor readings kind of went back to what it was before.
Okay, thank you.
I'll just jump in there, Tyler, to answer also. Lee and I, as not being engineers, are a little out of our depth, but we, our understanding is that the fiber optic sensors are being, creating a measurement based on reflected light. So there's no manual zeroing of the sensor, but rather the laser source sends light through the fiber optic cable and into the fiber optic sensor, and then is reflected backwards. So backwards, and we get a reading from that. So it's possible to get these baseline readings versus experimental readings as well.
Okay,
Okay.
thank you for clarifying.
Thanks, Tracy. And actually now I'd like to invite Dr. Tracy Popovics to make her comments about Lee's project.
Yes, thank you so much, Lee, for all of your hard work. And it has been such a delight to work with you. And I wanted also to thank the Orthodontics department for hosting this collaboration, if you will. It's been a wonderful opportunity for me to move in a new direction of research. And I'd also like to thank the American Association of Orthodontists Foundation, who also contributed to the funding of this research. It's really been invaluable to have the support of the orthodontics community for this work. And I just wanted to mention that I've spent many years of my life studying load transmission through dental tissues. And for those of you who don't know me, I'm a biologist and not a clinician. So my interest has always been in the biomechanics of these tissues and how stress is transmitted through them. And I have never had the ability to measure what's occurring within the periodontal ligament because it's such a unique space and so structurally complex. So this has really been exciting for me because it's the first opportunity that I've had to have a direct measurement of what is occurring in the periodontal ligament when a load is applied. So it has been very exciting work for me. As a non-clinician, I have a more naive view of clinical practice, but I would see the clinical relevance of this work as being that there's the possibility that different patients may have different treatment reactions to the same treatment, is my understanding. And there's also this possibility that there can be negative side effects to certain treatments as well. And we really don't know often what the basis for that is in the biology of an individual. So I see this as a potential tool for us to help understand how biological differences in the conditions of the periodontium or between patients may be able to be related to strain and stress distribution within the tissues associated with orthodontic procedures. So that's my hope for the clinical application for this work. And then I wanted to say that also I had the pleasure of meeting Lee when she was a first-year dental student, and it's been such a wonderful journey to see her develop into an orthodontist. And I'm very proud to be here today with her and very happy to have worked with her. This project has been very ambitious in that it's interdisciplinary, and that means that some of the time, or maybe even all the time, we feel a little bit out of our depth because we're not engineers. So I commend her courage for walking this path with me and taking the time and the patience to focus on this research with such determination and such attention to detail, and being such a pleasure to work with aside from that. She has been a wonderful teacher throughout, working with an undergraduate dental student, Isabel. Isabel has just really blossomed under Lee's tutelage and has created work of her own that has been really something that we can be proud of. So I wanted to just say thank you to all of you today, and congratulations to Lee on a job well done.
Thank you, Tracy. Now I want to allow Dr. Anne-Marie Boland to present Lee her virtual certificate.
It's here, Lee. You did get it. Hey, congratulations. We all enjoyed having you here, and I hope all of us are joining us to clap and congratulate you on a job well done, and wishing you the very best for a bright future. Thank you, Lee.
Congratulations, Lee. Okay, now we're moving on to our last presenter, who's Lauren Lewandowski, and her thesis project is Treatment Acceptance in Adult Anterior Open Bite Patients, a National Network Study. Lauren.
Okay, thank you. Oh. So my research is on treatment acceptance in adult anterior open bite patients. So let's start by defining what anterior open bite is. It's the absence of contact between the maxillary and mandibular incisors at centric relation. Reported incidence in the literature of this malocclusion ranges from about 1.5 to as high as 11%, and its occurrence tends to vary with age and between races. So anterior open bite is the result of dental, skeletal, and muscle components all acting together. Frank Worms waxed poetic when he said, "Into this potpourri, the orthodontist is required to venture with his or her mechanical-therapy. The orthodontist is called up to alter the system so that a more acceptable relationship is attained." So we as orthodontists are answering that call. We want to alter that system. We see these pictures and we're like, oh, must fix. So naturally, we're going to come up with some treatment plans. There are many options for addressing anterior open bite. Common treatment modalities include, but are not limited to, habit appliances like this tongue crib, braces, elastics, clear aligners, temporary anchorage devices, which I will call TADs in this presentation, and treatments as invasive as orthognathic surgery, which is also commonly known as jaw surgery. We also have extractions, myofunctional therapy, mastication exercises, headgear, removable functional appliances, the list goes on. So there are many options, and of course, what works for one patient might not work for another. So this patient walks into your office with anterior open bite, cross bite of the lateral incisors, upper lower crowding, deviated midlines, and a class 2 malocclusion. What things are going through your mind when you think about treating this patient? What options do you have? Would you use braces? Would you extract teeth? Would this person benefit from jaw surgery? What treatment is right for this person? So you know what your favorite plan is for this patient sitting in your consult room, and how do you discuss it with them? In the past, healthcare professionals have made treatment decisions based on what they believed was in the best interest of the patient. Sometimes this could include withholding information or even restricting choices. The dentist would say, okay, this is the diagnosis and this is how I'm going to treat you. So the practitioner participating in this study that actually saw this patient thought that they would be best treated with fixed appliances, maxillary surgery, and mandibular surgery. Ultimately, the patient decides what they want to do with their body. Providers need to meaningfully involve the patient when making treatment decisions and consider the patient's needs and desires. That's what our residents, Lauren and Sarah, are doing in this photo. This is vital to the field of orthodontics because our treatment plans may last years and involve multiple areas of dentistry. Additionally, patient compliance can have a major impact on the outcome of treatment, so patients really need to be on board with the plan. Orthodontists typically provide multiple plans for their patients, especially for complicated problems like anterior open bite, and the patients ultimately decide what combination of treatments they will accept. So my study is about what factors go into these decisions. Now that patient involvement in decision-making is more commonplace, there's a need for research into this dynamic relationship. Not much is specifically known about patient acceptance of treatment, but patient satisfaction with treatment and factors influencing communication quality have been studied. So I decided to look into these results from these investigations and see if they might correlate with trends in treatment plan acceptance. So a focus group was done to see how mothers decide what orthodontic office to use for their kids. And it found that mothers of an older generation relied more on recommendation, whereas mothers of a younger generation made their decision based on the comfort of their child with the office, doctor, and staff. So age might impact how one chooses their provider. Looking at motivation for jaw surgery, a study found that those over the age of 25 wanted to improve oral function and health as opposed to improving self-image and appearance. It was also noted that women were more concerned with improving their appearance, whereas men were more likely to seek treatment for social well-being. So gender might play a role there too. When looking at gender and anterior open bite treatment satisfaction, women were more likely to be dissatisfied, possibly because they have higher expectations for dental facial improvement. We've also found that patients with higher education levels might also have a higher rate of dissatisfaction with their treatment, possibly because they are more discerning when it comes to evaluating outcomes. When considering the relationship between a practitioner and a patient, there was a study that found that having a bachelor's degree was the strongest predictor for a patient's satisfaction with communication. But conversely, this study also highlighted a disparity in perceived communication quality for patients who are less educated, non-white, elderly, non-English speaking, and female. So we have an idea of what might influence a patient based on their own demographics, but what about the practitioner's demographics? With more women entering the dental field, as you can see by the population of this entire residency program, we need to consider the role of gender in the dentist-patient relationship. People's perception of how a gender should be seems to play a part according to some recent studies. Some patients said that they prefer a male practitioner, believing that they're less likely to be distracted by family demands, stay current with the latest advancements, and seem to be more in charge. Some patients said they prefer female dentists, saying that they are more likely to make them feel relaxed and to discuss their ailment rather than just solving it. Other research has found that female healthcare providers are more effective communicators than males, as they tend to interrupt less frequently and are more attuned to nonverbal cues and spend more time with their patients. So related to training and experience, one study found that patients were partial to locally trained dentists, which the examiners explained as a function of preference for practitioners with a similar cultural background. And the results of this research also showed that dentists with a greater amount of experience were preferred over those with moderate experience. So if all of these qualities impact selection, communication, satisfaction, they might influence a patient's likelihood to accept their provider's most highly recommended treatment plan. So back to our patient. We know what the doctor here wants to do, but what does the patient want? This patient was given a second option with clear aligners, but they actually ended up accepting the third option, which was a combination of fixed appliances and clear aligners. But why did the patient decline surgery and choose this particular plan? Well, the patient said treatment was too long. They said they did not want surgery, and they were getting married, so they wanted a quick aesthetic improvement. There are so many factors that can influence a patient's acceptance of a treatment plan. To find out what these factors are, I looked to the data collected from this prospective observational cohort study done by the National Dental Practice-Based Research Network. So all orthodontists and dentists that are part of this organization, as well as members of the American Association of Orthodontists, were invited to participate. 91 practitioners signed up, and they collectively enrolled 345 adult anterior open bite patients. So upon enrollment, practitioners and patients filled out surveys with questions relating to their demographics and characteristics. They also recorded the most recommended treatment plan and treatment alternatives. If patients declined the most recommended plan, the reason why was noted. So we used all of these responses to look for associations with likelihood of treatment plan acceptance. First, we looked at the stats for treatment plans overall, which had a 77% acceptance rate. We then broke this down into subgroups by treatment category. With a 94% acceptance rate for clear aligners, 89% for fixed appliances, 74% for TADs, and 60% for orthodontic surgery, we can see that the rate of acceptance generally declines with the increasing invasiveness of treatment. So what factors besides invasiveness influence acceptance? Initially, we had looked at the reported demographics and dentofacial characteristics univariately, but a person's decision to accept treatment is definitely multifactorial. So we used univariate analysis of all these characteristics to see which ones could have the potential to be predictive of a patient's likelihood to accept a treatment plan. When we looked at practitioner and practice demographics, it stood out that two regions of the United States, the Northeast and South Central, had higher rates of acceptance than the other regions. When we looked at patient demographics, it didn't seem like gender, age, or education were contributing, but patients with prior orthodontic treatment had a fairly high acceptance rate. And then for patient dentofacial characteristics, those with a concave profile, no posterior crossbite, and a normal facial pattern also had increased rates of acceptance. So when we look at one factor at a time, we might ignore the fact that many things play into someone's decision. For example, the patient I talked about before didn't want surgery, but she was also getting married. So she wanted something done fast. So we combined all of these characteristics into one statistical model to see which ones really explain the likelihood of patients to choose the first plan practitioners offer them. After performing regression analysis, having a normal facial pattern and no posterior crossbite no longer seemed to be contributing to the outcome. The final model included what kind of treatment the patient was offered, prior orthodontic treatment being in the South Central US or the Northeast, and having a concave profile. So these factors make a patient more likely to accept the doctor's most highly recommended overall treatment plan. Here's another patient. When you look at this malocclusion, do you automatically think surgery? I do. But this patient declined surgical treatment. 129 patients in this study had orthodontic surgery included in the most highly recommended treatment plan. 51 of these patients did not accept the initial plan presented to them. Was it because the plan included jaw surgery, or were there other factors? One of the biggest decisions an adult patient can make is whether or not to have surgery. It is expensive, it's invasive, it carries risk beyond typical orthodontic treatment. So patients making these decisions are definitely of interest. So we wanted to look at this subgroup of 129 patients more closely to see what really influences a patient's decision to have surgery. And we wanted to know if these factors are similar to those impacting overall treatment acceptance. So the overall acceptance of surgery is 60%, which is lower than the frequency of treatment plan acceptance in general, which was 77%. After doing a univariate analysis, the factors that seemed significant under patient demographics were gender and having insurance that covered orthodontic surgery. When looking at dentofacial characteristics, we noticed that acceptance rates for patients with severe crowding were actually pretty low at 33%. So again, if we look at all these factors individually, we may accidentally include or miss things that may or may not be significant predictors. We combined gender, insurance covering surgery, and severe crowding into a multivariate model. And after regression analysis, gender did not maintain significance, so it was eliminated. So having insurance covering surgery makes a patient 3.5 times more likely to accept the doctor's most recommended treatment plan, including orthodontic surgery. However, having severe crowding makes a patient less likely to accept the recommendation for surgery, which is interesting. We looked at the survey responses for the 129 patients whose most highly recommended treatment plan included orthodontic surgery. 85 of them said that their main motivation for seeking out treatment was addressing their anterior open bite. Crowding was the second most selected reason for treatment. And patients were also able to select as many other reasons for wanting orthodontic care as applicable, and those are listed in the column on the right from most to least popular. So we can assume that patients with more severe malocclusions were recommended a plan including orthodontic surgery to treat their anterior open bite. It's not surprising that these patients would experience problems that interfere with their lives and subsequently seek out orthodontic treatment to help address these. Many of these patients said they were unable to bite food with their front teeth and had problems with their bite and their jaw joint. For the 51 patients who declined the most recommended treatment plan that included orthodontic surgery, most responses were related to not wanting jaw surgery. These patients also felt that the treatment was too risky or too costly. I would say this isn't surprising considering the invasiveness of orthodontic surgery. So alternative treatment plans accepted by patients declining a treatment plan including orthodontic surgery. Some of them were very simplistic, either just clear aligners or fixed appliances with elastics. One selected both aligners and appliances. And on the other hand, some patients threw everything at their interior open bite but the kitchen sink, the sink in this situation being surgery. Some patients accepted treatments with several components, TAD plates, interproximal reduction, elastics, speech therapy, tongue cords, occlusal equilibration, vibration therapy, anything to avoid surgery. So we have a lot of information here to think about. And what does it mean for practitioners and their patients seeking treatment for open bite? Well, overall, we found that the more invasive a treatment plan is, the less likely patients are to accept it. Most patients said outright that they do not want surgery. Aside from being too risky, patients often stated that they declined to have their surgery because treatment was too costly. Aligners, which aren't very invasive, were only declined twice, and cost was the reason why for both of these patients. Plans with braces were often declined because patients just did not want braces, and not surprisingly, they chose to have treatment with clear aligners. So there isn't a significant difference in overall acceptance rates according to practitioner demographics, except for region. It's not clear to us why the Northeast or South Central US have higher acceptance rates. And I think that nothing else came up as significant because the adult patients in our study have already chosen their provider along whatever preferences they may have as far as experience, gender, place of training, etc. Yeah, if anyone can explain the Northeast or South Central, let me know. So patients with a prior history of orthodontic treatment are more likely to accept the provider's most highly recommended plan, I think because they want to ensure that their second round of treatment is successful. Orthodontic treatment requires dedication of time and effort, and it could mean having to avoid your favorite snacks. So not many people would want to do it a second, let alone a third time. We also found that patients with a concave profile are more likely to accept the most highly recommended plan. Concave profiles may not be considered aesthetically desirable, and these patients may be more aware of their appearance and seek out treatment to help improve it. Insurance being significant is not surprising. Orthodontic surgery is expensive, especially when double jaw surgery is needed. Without insurance coverage, patients may not have the finances to pay for such treatment. So I think that patients with severe crowding not accepting the most include surgery has to do with extractions being a viable alternative. This certainly follows the trend of choosing a less invasive treatment if one is available. Practitioners may believe that an open bite can improve without surgery due to the alleged bite deepening effect of space closure after extractions are done. So if extractions were presented as a second option, an alternative to a plan involving surgery, patients might have been inclined to agree to that plan instead, as extractions are generally less invasive, risky, and costly than having jaw surgery. So a limitation of this study is that people elected to participate, which means that there could be some selection bias in both the patients and practitioners. Practitioners participating in the involved organizations may be of a certain demographic and have a method of practicing that isn't representative of all the providers in the country. Most of the doctors enrolled in this study are male, white, and solo practice owners. So patients were asked to participate in the study, and those that agreed may be more compliant because they know that they are being studied. They may also fill out surveys in a way that they think researchers want surveys to be filled out. Practitioners were also told to prioritize enrolling patients who are closer to the end of their treatment, just so they could be included in the study. And there could be follow-up done on these patients as well. So there could be errors due to an imperfect recall, as the forms would have been filled out weeks to months after treatment was actually started. The strength of this study, though, is that it is one of the largest samples ever collected across the country for evaluating open bite treatment in non-growing patients. The large number of patients and practitioners included in the study makes the results generalizable. It's fairly realistic to think that these outcomes could be expected in a general orthodontic practice. So in conclusion, we found that treatment plan acceptance decreased with increasing invasiveness of treatment modality. The South Central and Northeast regions of the United States have higher rates of acceptance. Prior orthodontic treatment and concave profiles predict the patient's acceptance of the most highly recommended plan. Patients with insurance coverage for orthodontic surgery were significantly more likely to accept the plan with orthodontic surgery. and patients with severe crowding were significantly less likely to accept the plan with orthodontic surgery. We also found that procedure cost and safety were among the most common reasons for declining the most highly recommended treatment plan. So I'd like to thank the National Dental Practice-Based Research Network and the UW Orthodontic Alumni Association for their support and funding of this research project. Thank you to my committee members, Jeff, Greg, and Ellen, for all of your time and guidance. I'd like to thank my mom, dad, brother, aunts, uncles, cousins, all my family for the support, check-ins, and care packages. To all my friends from home, college, and dental school, thank you for being the best cheerleaders, working with the time difference, and coming to visit me across the country. A big thank you to my girlfriend, Fabiola, for always pumping me up and bringing me support cookies and donuts. You're amazing, and happy birthday. I'd like to thank the faculty for all of their time spent teaching us. I've learned so much from you. And thank you to our amazing staff for dealing with us, dealing with our patients. We really couldn't do it without you. To the first and second year residents, thank you for all the fun times and all the help you've given us, especially in these last few weeks. It's so appreciated. I'm happy to be sticking around so we can keep hanging out. And lastly, to my class, I couldn't have asked for better co-residents. I love you guys, and I'm so happy to have found not only incredible colleagues, but lifelong friends. Oh. And any questions or suggestions?
Okay, there's a question from Mike Harefield. He's saying we need more studies of this kind. As healthcare professionals, we must be able to speak the unspeakable. However, okay, so let me get to the question. Does this degree of influence really exist? If so, how might this effect be measured and studied? Oh, I'm sorry. So he's saying some orthodontists are very effective at promoting the one and only plan acceptable to them. Does this degree of influence actually exist? If so, how might this effect be measured and studied?
That's a good question. There were a number of patients in the study that were only given one treatment plan, and that's the treatment plan that the patients accepted. Of course, this is what was recorded by the practitioners, and for some patients, this was done after the fact. So maybe if a treatment plan was briefly discussed, the practitioner didn't include it on the form. But yeah, there were a significant number of patients that only had one treatment plan offered to them that they did accept.
Okay, and Lauren, I have a question. So you guys have any idea why Northeast was more accepting?
No. I don't know, being from New York City, I'm like, I don't know if that's the case, but it depends on where the offices actually are. Mm-hmm. Are they in New York City or are they in upstate New York? I feel like there are a lot of regional differences. Also, it could be that there are only a few practices in the South Central or the Northeast that contributed to this study, and maybe those certain providers are super great at talking with their patients and getting them to commit to their most ideal treatment.
Okay, yeah, that's sort of interesting. Thank you. Good job. Good presentation. So now I'd like to allow Dr. Jeff Greenlee to make a few comments about this project. Jeff?
Hi, everyone. Thanks, Lauren, for a great presentation. It came out really well. Thanks especially to the rest of our committee who worked on this project with us, and certainly for our alumni for supporting in part our efforts, and as well for all the UW faculty for their time and dedication to teaching our residents. Lauren came to this project from another one that she had started, but that didn't pan out, so she brought her energy and ideas to the execution of this project, one of the many ones that we've got going out of our many reams of data from the Open Bite study we did through the national network. So she's brought a really great amount of energy and enthusiasm, and I'm looking forward to turning this project into a publication that we can add to the several publications that have come out of the project. In addition, it was great to have Lauren in clinic. She's a great provider. She brings a lot of fun energy to patient care, and she's a very good clinician. And all of 5 of our residents were really great to have, and it was a pleasure to teach you all. And we're looking forward to all the great things that you're going to do, and we're very proud and very happy that you have reached this day. So thanks to everyone. Thanks to Lauren. Great job, everybody. And welcome to the UW alumni family.
Thank you. Congratulations, Lauren. So now I'd like to invite Dr. Anne-Marie Boland for the certificate presentation.
This is so boring. I mean, this will be so much more fun. Next year, we're going to do this in person. And Lauren, congratulations. Last but not least, you did it. Fantastic presentation. Great class. We'll all miss you. And welcome to the family. Thank you.
Thanks. I think now I'm going to turn it over to Greg for introducing Dr. Peter Shapiro.
Thank you, Burju, and thanks to all 5 of our graduating students. Really nice presentations, a lot of work put into those, and we appreciate you sharing your findings with all of us. So at this time, I'd like to introduce Peter Shapiro, but of course, Peter Shapiro needs no introduction to anyone in the UW orthodontic family. But for those of you who are friends and guests, Peter served as the 4th chairman of our department. And in fact, Peter was the chairman who accepted me into the program. I still remember back in it would have been 1986 when I interviewed. I told Peter, I said, Peter, I plan to come here and learn as much as I can and go right into private practice. That is my goal, and that's what I'm going to do. And it's funny, I don't know if it's him or me who is more surprised, of course, at the trajectory of my career, because it was completely unplanned. What I can say is Peter loves this department. His relationship with the department spans almost 50 years. And even now, he continues to devote considerable time and effort supporting departmental activities. Just this past year, Peter accepted the role of president of our Alumni Association. And during this special Zoom thesis day, I asked Peter if he would make some short comments and talk about his long relationship with the department and discuss where we've been, where we are, and where we're going. So Peter, I turn the mic to you.
Okay, thanks, Greg. Am I on? I'm on. Yeah, so I guess I made a lot of mistakes when I was chairman. Accepting you might have been one of them, Greg, but it seemed to have worked out okay. Congratulations to the 5 graduating seniors. Very impressed with your research. Good job. Special congratulations to Sue Herring, who I hired and was a great addition to our department for many, many years. I'm going to use my few minutes to highlight Al Moore, actually, in the history of the department, because I was kind of shocked when I got the invitation that this was actually the 40th Alton Moore lectureship, which is pretty amazing to me. And I remember with Don and Vince, some of the faculty talking about starting this 40 years ago. But the department, well, let me go back. The dental school started in 1948. The construction of the health sciences complex began in 46. And they started 4 different schools at that time: medicine, dentistry, nursing, and pharmacy. And it's on the present site. The difference is now it's much larger, and the golf course which I never saw, which was outside of the hospital, is gone. The dean at the time was Ernie Jones, and we know his name because of the Ernie Jones lectureship. I never met him. And there was a group of orthodontists in the Seattle area called the Northwest Tweed Study Club. And the members were Emery Fraser, Paul Lewis, Alan Bishop, Bill McGovern, and Milt Fisher. And those guys, those men at that time, influenced Ernie Jones, the dean, to start a orthodontic program. And they further influenced him to hire Al Moore. They had met Al Moore when he spoke at a national angle meeting in Santa Barbara. Very impressed with his presentation. And of course, Al had the gravitas at that point, even being a young man from his background. And they successfully persuaded Al Moore to come and head the department and start it. He arrived in 1948, and that's when we consider our department being founded. He came from the University of Illinois. The University of Illinois was the first graduate program in the United States. It was founded by Alan Brody. Alan Brody was kind of the man in orthodontics in the 1930s and 1940s because he was the direct link to Edward Angle. He was in Angle's last graduating class. And according to some correspondence I saw, Brody was considered by Angle to be probably his best grad. So Brody started the program in Illinois, and Al Moore became a graduate student. He finished the program in 45. He stayed on in the department for 3 years teaching and also earning his MSD. So in 1948, he arrives in Seattle, starts figuring out how to run this program. And he had the good fortune of knowing Dick Riddell. Dick Riddell wasn't a graduate of Illinois. He was a graduate of Northwestern a few years later. And the chair of that department was Thompson, Jack Thompson, who was also a graduate of Brody's program in Illinois. Dick, and by the way, I say the names Al and Dick so easily now, it rolls off my tongue. I can tell you that it took me several years being on the faculty before I could choke it out and could say Al and Dick. So it's nice for me to be able to do that now. But Dick was on the way to California, he'd passed the boards, and Al convinced him to stay and help begin the program for a year, a temporary appointment. And obviously that changed, and Dick stayed forever. So the first class was accepted in April of 1949. There were 4 students at that time. Bill Gilmore from Yakima. His son, Charlie, by the way, is an alumnus of our program and past president of the Alumni Association. Ken Kahn, Ken Orman, and Bill Takano. And the faculty were the 5 founders of the program, Al and Dick. And 6 months later, they accepted 6 more grad students. One of them was Jerry Donor. Jerry Donor was one of my clinical instructors. And then in June and December of 1950, after a 5-quarter program, those people graduated. There was no difficulty in getting students to the program. And I think part of the reason was because of the reputation of Al Moore in particular and Dick Riddell. In 1950, there is a great issue of the Angle Orthodontist, which is called the University of Washington issue. And you can find it on our website. And in it, Al describes the basis, the philosophical basis, and lays out how he's going to run the program. And he admitted at that time that he patterned our program after that of Brody and Downs at Illinois, Jack Thompson at Northwestern, and Wendell Wiley in California. And having that kind of background gave the program a lot of credibility. I should point out that all of this stuff that I'm talking about in much greater detail and is fascinating is on our website in the history section. And John Moore is the person who really got all this stuff together and put it all in there. And it's just fabulous, and we're going to expand it. If you go on now, you can see a timeline of the department by year. And it's really kind of fascinating reading. It goes back to Brody's correspondence with Angle, all those kind of interesting things. And I'll point out now that we're going to expand the website in the history section. I'll write about this more when we send out our newsletter, but we're going to solicit photographs from all of our alumni, decent photographs that we can add to our website. I think it's just going to be fantastic to be able to go back to the class of 73, which I was in, and look at all the stuff that happened at that time. So the other thing that kind of happened that really set our national standard a bit, I think, was there was an interview in the Journal of Clinical Orthodontics in 1970, and it was an interview with Alan Dick. And it was actually influential in me coming to the University of Washington, because I'm from the Northeast, Lauren, and we do things a little differently, but everybody I talked to about orthodontics had something really wonderful to say about the University of Washington. And I'm sure it came from that original Angle article and then the JCO article. And it talked about how, philosophically they're going to run the program. When I started the program in 71, there were no interviews at that time. So when I came out here, it was cold turkey. I didn't know anybody. I'd never been in Seattle. It was, it could have been a difficult situation. The faculty at that time were really primarily Alan Dick and Ben Moffitt. But my main teachers for most of the hard stuff were the younger faculty members, Bill McNeil, Don Jundeff, Bob Little. They weren't that far ahead of me in terms of longevity, but they were infinitely more educated about orthodontics than I was. And there was a great team of instructors. My clinical instructors, besides them, were Andy Haug on Monday. I had Al Moore and Don Jundeff on Tuesday for mixed dentition, Jim Dana and Paul Lewis, one of our founders, on Wednesday, Jerry Donor, who was a member of the first class, and Jack Keller were on Thursday, and then Jim Nelson and Dick Riddell were on Friday. And the other person that was really great was Les Erickson. Some of you may remember, he taught wire bending, and the highlight of that was that his wife baked fresh stuff for us every Wednesday morning. So it was kind of the way the program was set up. We were, from day one, we were treated respectfully and warmly. And Bill, I've mentioned this to Bill before, but it was kind of the tone setting for the whole deal. We had our first seminar with him, it was called Orientation. Bill sits down with 11 of us and he says, "Call me Bill." And I had this thought in my mind, I don't think I could take 2 more years of dental school. I enjoyed dental school, but it just is enough. When Bill said, "Call me Bill," that set the program tone. And it was the way things were run here was great mutual respect between the faculty and the students. And to credit Bill one more time, there's one quote that I really like from a newsletter, quote, "Graduate students and junior faculty members were given the freedom to pursue their own interest in a non-competitive, non-hierarchical, and mutually supportive environment." And that's the kind of environment that Alan Dick set. Don followed through with it, and I hope that we've done the same thing all the way through. The first newsletter I found was in October 1954. Dick Riddell put it together. It was typed and mimeographed, and it was pretty folksy. It had kind of addresses where people were, some clinical tips and stuff like that. It was called The Word, Washington Orthodontic Reader's Digest. In the 1962 February newsletter, and they were doing it 4 times a year, Al Moore in his column from the chair announced the formation of the Memorial Fund. It was originally set up to honor Bill McGovern, one of our founders who died. So they set up this Memorial Fund, which became our Orthodontic Memorial Fund. And of course, the greatest conduit for alumni contributions to support the program. The first meeting of the Alumni Association was August of 1962. Jerry Donor was president at that time. Interestingly enough, the dinner speaker was Wendell Wiley. And I've seen the program, and Jerry Donor and Al Moore gave a talk entitled Postnatal Development of an Orthodontist. I don't know what that is. I'd love to see what that was all about. My first alumni meeting was 1973, shortly after I finished the program. It was a memorable meeting for me in several respects. One of them was that they invited Alan Brody as a special guest. And so he was there, and it was fortuitous because after the meeting, he went home, and a couple of weeks later, he died. I did have an interaction with Brody. I had done a research paper on long-term crowding of incisors in treated cases. And Brody came up to me sometime during the meeting, and he said, I don't remember whether he called me Peter or dummy or whatever, but he said, are you aware of this paper? And he quoted this paper. And I said, yes, I'm aware of it. And he said, well, why didn't you put it in your paper? So I don't know how you would hem and haw with Al Moore at this point, or Dick Riddell, but I really hemmed and hawed with Alan Brody. And that's my main, that's my connection to Angle through Brody, is that he wasn't happy with the way I wrote my paper and referenced people. The Alumni Association, when I was chair, was an incredible organization. It provided us with our main monetary support, financial support. As of now, we didn't have a lot of outside grant support all the time, and most of our research was funded by the Orthodontic Memorial Fund. It gave us, because of our membership within the alumni organization and our funding, it gave us a lot of credibility within the dental school. And I felt that credibility whenever I had to deal with the dean or other faculty about things that were going on. When the dental school, in its infinite wisdom, finally came up with enough money for one computer. When I was chairman, by the way, I didn't have a computer on my desk, but they decided to give one computer to one department to start off this thing. Well, we were a small department, we weren't going to get it. I remember going to the Alumni Association. I think Doug Cameron was president at that time. And I said, we need a computer. We need it for Jim Clark to help us with our AV stuff. And sure enough, the department provided the money for that. The Alumni Association provided support for the ABO. When the grad students went to take the ABO, we provided some support. The big thing really that happened to me in terms of the Alumni Association was right when I finished, I felt like I had one piece of unfinished business. And I really wanted to establish a chair in the name of Alan Dick. And the way the university works is sometimes something happens, they say, we have a grant that's available for matching. For example, if you have an idea in a certain area and they give you like 2 weeks to respond. Well, we've been kind of working on this idea, and the university, the state through the university said we will provide matching funds to established endowed chairs. And we went to the university and said, we have $250,000 ready from the Alumni Association, which was matched by another $250,000 from the university that gave us a $500,000 start. And then the next year, I raised the other $1 million from our alumni to start the Moore Riddell chair. And it was another example of when we needed the alumni, they were there. And it didn't happen in my time, but of course, the clinic remodel was another big thing. So I'm going to finish my comments by making a few pleas. The first one is the alumni have been very, very generous. Recent alumni haven't been as generous, partly because they probably haven't made enough of an income yet. But I would really love to see recent grads, the 5 of you can start, to become dues paying members of our organization. It's not a lot of money, but the more members we have, it speaks well for us in the greater university environment. The second thing, as I said, is that we are going to expand the website. I'll have more about this when we send out the newsletter in May, but we're going to solicit photographs, if you will, from your days at UW, and we're going to find a way to incorporate that in some kind of a time sequence on our website. And then the last thing is that we're planning at this point on having our 75th reunion alumni meeting in Seattle in 2023. So that's 2.5 years from now. We're basing it on the time that the department was started, 1948. And we will plan on having a great meeting. We hope a lot of people will come. It would be great to see everybody. So thanks everybody for attending Thesis Day. Well done by the students. I hope we'll be seeing everybody next year at Thesis Day. And I hope, even though it's a long time off, I hope you'll be thinking about 2023 in Seattle. Thanks, Greg. Thanks, everybody.
Thank you, Peter, for sharing those comments with us. We appreciate it. And as we come to the conclusion of our Thesis Day activities, I would like to just recognize and thank certain people and entities again. Of course, thanks to all of you for attending. We had about 80 people, I think, attending from all over the country, which is wonderful. I would like to thank the UWOAA. As Peter mentioned, they have really provided unbelievable support to this department. The orthodontic department, we're really envied by many other departments because we have this wonderful alumni association. In particular, Peter for being president, of course, all the members, but Peter and also Sally Gee, who is our executive administrator. She does a lot of work behind the scenes. I want to thank our wonderful staff. They really make the department work. And of course, our faculty. Our faculty are really dedicated. Many of our faculty have been here 20, 30, even longer than that. It's really amazing that the faculty have had such longevity here in the department. And finally, I really want to invite everyone to turn on your videos and unmute yourselves, because I'm looking at the gallery view and I'd like to see every square filled up with a live person smiling. And in just a second, when I see all these squares filled up, what I'd like to do is have everybody show these 5 graduates how much we appreciate them, how proud we are, and congratulate them with a real big round of applause. So now let's do it. Congratulations.
Yay.
Okay. Great.
Yeah, I'm muted now.
So all of you 5 grads, again, our deepest congratulations. Come up here, collect your certificates, or would you like us to come down? We can come down. It's a little nicer in the conference room, isn't it? We'll come down.
Or you guys can come down.
We'll come down. And again, thanks to each of you for attending. We look forward to our meeting in 2022 when it will be in person. We hope it'll be at the Pacific Tower again with that wonderful venue, wonderful view of Seattle and the mountains. So until that time, my very best to all of you. Stay healthy and look forward to seeing you soon.
Thank you.
Thank you.
Congratulations.
Very much. Thank you.
Congratulations.
Hey.